May of this year, that is March 2021, and so I will just request our Secretary, Dr. Pankaj Bandarkar, to start the show.
Good morning, friends. First, let me wish you all happy Holi. As you know, this is the last program of this year, and that is World TB Day and International Women's Day. So it will be in two sessions. The first session is about the World TB Day, and we have Dr. Girish Ranjan Dixit, who will be talking about TB management in 2021. Of course, we have other speakers like Khushi Deshpande, Dr. Kar, Dr. Mudul Shah, Dr. Darshanan, Dr. Vijay Kumar. I welcome them all on behalf of IMA Mumbai branch. Second section is regarding the International Women's Day. And here we have very eminent speakers. His Grace Prabhu Vilas, who is a paid speaker, author, a storyteller, lifestyle coach, and he will be talking about developing emotional intelligence. So we have a very good program today, and I hope you will all enjoy that. So right away, I'll hand over to Dr. Sujata Attar, our president, to deliver her message. Dr. Sujata
Attar. Good morning, friends. I welcome you all on behalf of IMA Mumbai branch. This will be my last presidential speech. Next Sunday, 4th April, is the installation of the new team, and the incoming president is Dr. Jitesh Mehta. Today's webinar is on World TB Day celebration, and this year the theme is "The Clock is Ticking," and this is because the commitment that is made to end TB is still not reached, and we have to raise awareness about TB. And that is why we will be giving you insight of what is happening now in 2021. And our second session is on International Women's Day. It is a global day celebrated using social, economic, cultural, and political achievements of women. And the theme for this year is gender equality by 2030, where the women will get the reproductive rights and violence against women. And this day is marked to see the achievement that is made. Without wasting much time, I hand over the proceedings to Dr. Anil Awar, Assistant Director, IMA CGP. Over to Dr. Anil Awar.
Thank you very much, Attar Madam. And we begin today's program.
So if you can mute the other device.
We are starting with a nephrology program, and have this program, we have a very eminent person, Dr. Khushi Deshpande. Dr. Khushi Deshpande is Director of Critical Care Nephrology and Renal Transplant with the Nephrology Department of Sir H. N. Reliance Foundation Hospital and Research Center. After his MBBS and MD, he completed DNB Nephrology and DM Nephrology. He received gold medal in DNB Nephrology awarded from the hands of Dr. APJ Abdul Kalam, the President of India. He completed clinical fellowship in nephrology, followed by clinical fellowship in renal transplantation at the University of Toronto, Canada. He has been trained in management of patients with various renal problems, such as ARF, CRF, hypertension, nephrotic syndrome, nephritic syndrome, acid-base and electrolyte disorders, CAPD, and transplant patients. He has presented multiple papers at various national and international conferences and has several publications in peer-reviewed journals to his credit. His areas of special interest are peritoneal dialysis, across blood group kidney transplantation, and marginal donor kidney transplantation. Today, sir will be talking to us on Introduction to Critical Care Nephrology, a very different branch altogether we have come across in nephrology. Over to Dr. Ruchi Deshpande.
Thank you, Dr. Anil Awad, for the kind words. Thank you, Dr. Sujatin Nisa and Dr. Jitesh and the entire IMA for the opportunity to speak to all of you today. Now, this is a topic, I mean, when you, I'm sure when all of you read critical care nephrology, it must have come like a surprise, right? I mean, what is critical care nephrology? So I think I will start with the introductory slides on what is it that we are planning to do at Reliance. And so I'll just start the screen share. Yeah. Okay. So I'll let this first 5 to 10 minutes of this talk is actually designed at presenting what is critical care nephrology. I mean, this is a new concept to all of us. And this is a concept which is already there in the Western countries, not yet so much in our country. And we are one of the first departments in the entire country to launch critical care nephrology. And I thank our trustees of our hospital, our dynamic CEO, and the entire management for giving me this opportunity. And I also thank Dr. Mayur Patel and our critical care team with Dr. Mehul Shah, Dr. Darshana, Dr. Arindam, and Dr. Vivek for kindly agreeing to support me, because as you know, this is teamwork. And I also might thank all my nephrology colleagues in the hospital for helping me and continuing their support in driving this program forward. So without much further ado, let me introduce to you the concept of critical care nephrology, because all the discussion around this topic we are planning to do in the form of a panel, because we thought that would be more interactive and easily understandable for everybody. So why a critical care nephrology? Sorry? Am I audible clearly? Mehul, am I audible clearly?
Yes, sir.
Yeah, thanks.
ऑडिबल ही नहीं है ना ये
Chirag?
Yes, sir.
There's too much disturbance in the background.
Yes, sir. We have just muted everyone in the panelist, so you can
Thanks.
continue.
Thanks. Okay. So why critical care nephrology? I mean, look at the numbers up there. 1 out of every 3 patients in the ICU develops some form of acute kidney injury. 5 to 7% of hospital admissions are due to acute kidney injury. However, 20% of all hospital admissions are complicated by some form of acute kidney injury. And therein lies your importance of having such a branch or such a specialty, and how you run this program is very critical to the outcomes. Look at the incidence of acute kidney injury hospitalizations, how they have gone through the roof over the last 30 years. Patients die because of kidney injury more than other illnesses in the hospital. Look at the common causes of AKI in the hospital setting. Almost half of the cake in that diagram is an acute tubular necrosis, and a significant share is pre-renal. And these are all where we could, actually play a major role, not just in treating them, but more importantly in preventing them. And therein lies the importance of this concept of critical care nephrology. Look at the different causes of AKI, which all of you are very familiar with: renal, intrarenal, and postrenal. But what is more important, it is to reduce the incidence of these AKIs. And what is critical is the timing of the nephrology concept. It has been clearly shown that an early consult with a nephrologist in patients with AKI reduces the risk of further decrease in kidney function. It's very clear. Okay. It improves the outcome in acute kidney injury survivors. People who have survived the acute kidney injury later on, the incidence of mortality in them with long-term follow-up is actually lower if you are going to treat them early with a nephrological care. So the AKI pathway, which you are going to talk in a lot of detail in the panel, it's about what is AKI pathway, it's acute kidney injury pathway, which means detect them early, detect them on arrival to the hospital, follow them, and ensure adequate outcomes, optimum outcomes. So there has to be a triaging system. There has to be a system whereby these patients are picked up by our system when they enter the hospital. And this is a hospital-based care service, which will help in improving the outcomes, not just of kidney patients. Every single patient walking through the door into the hospital is going to be benefited by this pathway. First consultation of at the hospital, the triage, depending on the score which we will use to decide low risk, moderate risk, or high risk. And based on their scoring, we will decide whether the patient needs a nephrology consult, whether the patient can will be observed for a period of time, or whether the patient can go just for observation. And suppose the patient is in low risk. And then the primary doctor can refer to a nephrologist of his choice or her choice. But as a team, as a director of the program, along with my team, we will be following the patient in the background, ensuring optimum outcomes. What are the aims? It's to improve the patient outcome, it's to minimize the degree of the insult to the kidney, reduce extra-renal complications, restore renal function to pre-AKI levels, and to reduce the mortality. Ideal renal replacement therapy we'll talk about much more in the panel. There are different modalities of renal replacement therapy which are available in the hospital, whether it's intermittent dialysis, whether it is low efficiency dialysis, continuous dialysis, every modality is available. Beyond renal replacement, the third part of our program deals with is blood purification technology. And this may be new to some of you. It deals with cytokine removal. And cytokine removal, you must have heard this word cytokine storm. That's not new to any of you now. And how does cytokine removal in sepsis, cytokine removal in COVID, that's more familiar. So this has helped outcomes. And these are the various indications where the cytokine storm happens. Surgery, sepsis, trauma, burns, severe infections, ARDS. And it leads to increased mortality by multi-organ dysfunction. There are different types of filters. This is one of them, which helps us in surface adsorption of these cytokines and improves the patient outcome. We have facility for artificial liver support devices, including Mars. So basically, a lot of things, ECMO, which we'll all be covering in the panel discussion. So this was just an introduction. Critical care nephrology is an upcoming concept. Sir H.N. Reliance Hospital is the first hospital to give this concept live and start a program for critical care nephrology, and it will ensure best kidney care to your patients who will be coming to the hospital. All the patients will be given appropriate organ support in cases prior to surgeries like your bypass surgeries, cancer surgeries, multi-organ transplant surgeries, poisoning center. I mean, it has a major role in poisoning, which we'll talk about. The AKI pathway, which we will establish, will help in identifying and triaging the patients on arrival to the hospital. So we will know what is the risk of them developing kidney injury during their stay in the hospital. And this will help us decide how much of a follow-up they are going to need or not need. Overall aim of this program is to improve the outcomes of patients with kidney disease. Now I will hand over to Dr. Arindam Kar, our Chief Intensivist at Reliance Hospital, to lead the panel discussion, and all of us, myself, Dr. Mehul Shah, Dr. Darshana, and Dr. Arindam will be part of the panel. Dr. Vivek is not there with us today. Right now, he's down himself with COVID and fighting it. So we wish him good luck to recover soon. But the remaining of us here today will drive it forward. Arindam, over to you.
Hello, Dr. Rishi.
Yes, Arindam.
Can I take?
Yes, sir.
Can I take the liberty of?
Of course, Dr. Jitesh. You have complete. Please feel free.
Thank you. Thank you. Friends, we have 4 panelists with us: Dr. Arindam Kar, Dr. Mehul Shah, Dr. Darshana Rathod, and Dr. Vivek Kumar. I should just briefly introduce them. Dr. Arindam Kar is the Chief Intensivist Department of Critical Care Medicine, Sir H.N. Reliance Foundation, and HOD CK Birla Group of Hospitals, Institute of Critical Care. He is the National Security General, Indian Society of Critical Care 2000. He has launched Medica Home Care Services to deliver health care at every person's doorstep. He is the recipient of Chikitsa Sanman Award, the Best Doctor of Bengal Award in 2019. Dr. Mehul Shah is a consultant in the critical care medicine at HN Reliance Foundation Hospital, post as well as trauma intensive care. Dr. Shah has extensive national and international experience in multi-speciality intensive care, heart and lung transplant units, ECMO, and ventricular assisted devices. Dr. Darshana Rathod. She is a consultant in the critical care medicine at Sir H.N. Reliance Foundation Hospital. She has extensive experience in medical emergencies, medical intensive care, and surgical intensive care units. Her areas of specialization are invasive and non-invasive mechanical ventilation, intra-aortic balloon therapy, and hemodynamic monitoring. She has expertise in operating and providing the protocolarized care in ICU. And Dr. Vivek Kumar is a consultant in the Department of Critical Care Medicine at Sir H.N. Reliance Foundation Hospital. He is a certified instructor with AHA for basic and advanced cardiac life support with WIN focus for point of care ultrasound with Hong Kong. He is trained with Hong Kong University for basic assessment and support in intensive care. So I invite all the panelists to start their panel discussion. Over to you, Dr. Kar.
Thank you, sir. And, welcome to you all, and we have sacrificed your Sunday morning to attend this IMA CME. My first program based out of Mumbai. I've just very recently shifted to this lovely, vibrant city, but maybe we are again facing the COVID problem. And I thank the HN Reliance Foundation Hospital Authority to come up with this brilliant idea led by Dr. Rushi Deshpande, and and also my colleagues, Dr. Mehul, Vivek, and Dr. Darshana. All of us would be supporting and delivering this lovely concept sort of thing. I'm not sure whether Dr. Vivek would be joining, but this entire program was conceptualized by Dr. Rushi and primarily by Dr. Vivek, supported by rest of us. So I would start the panel discussion, which should not be more than 30 to 40 minutes. And then with the permission of the IMA authorities, we might take some questions if there are adequate time. So the next slide, please. Yeah. I think we have a little bit of, can I do my screen sharing? It would be easier if it is done. Yep. Okay. Yeah, I think this would be better. Just a minute, sir. Okay, so the initial part, I think we have a little bit of that how many ward and ICU patients do get a nephrology issues of hospitalized patients. How many of the hospitalized patients may have an occult, not that overt nephrological issues, or may develop renal disease or renal issues in the due process, and what is the impact of the renal disease in outcome of critically ill patients as well as the ward patients. So I would ask Dr. Darshana to come up with the answers. Yes.
Thank you, IMA, and can you all hear me?
Yes.
Yeah. So thank you, IMA, as well as our critical care team and Dr. Rushi Deshpande for inviting us. Just a brief about what Dr. Rushi Deshpande has already told in the initial introductory slide was about the incidence of the acute kidney injury, which we are seeing. And recently it has increased, as you all know, that almost around 20% of the hospitalized patients develop AKI, and out of the 20% of the hospitalized patient, almost 33% land up, having a mortality rate is around 33% in these patients, and 50% of the patients in the ICU also develop it. And we see that every third patient in the ICU is a patient who has acute kidney injury. Many of the factors which we already know, because why this kidney injury occurs, especially in the ICU, is because of the basic things that the patients come to the ICU, mainly hypotension, the drugs that we are using, the most of the drugs which we use also cause the hypotension. And the sepsis is one of the factors which we will be coming across in the further slides, which we will be explaining. The main concept about critical care nephrology that we are trying to draw over here is to reduce the mortality related to this acute kidney injury, which is preventable, and which is what we are going to discuss further.
Okay. Sorry, I think I am. Okay, the next would be that what might be the impact, if I can go to Mehul, that we are all facing a little bit of the COVID issue. So what had been the impact of COVID on acute kidney injury? We all know we had a acute renal failure and all others, but what had been an impact of COVID on acute kidney injury? Dr. Mehul.
Yes. Good morning, and can you all hear me?
Yes, we can hear you, Mehul.
Yes. All right. Thank you once again to IMA, to Dr. Rishi, and to my colleagues. It's been a pleasure being here. So with regards to acute kidney injury, we all heard Dr. Darshana talking about the incidences of COVID, the incidence of acute kidney injury in normal patients, and now we hit with this pandemic. And a couple of recent studies done in 2019 and 20, which talks about the incidence coming out from Wuhan also for risk factors for patients with COVID. The conclusion was that AKI is not an uncommon, but an extremely common entity that happens and leads to a high hospital mortality, especially in COVID patients. I'm not sure if you all are able to see the slide. Yes, you all are. Okay. So if you look at the slide, you've seen that have studied more than 1,392 patients, and in all of them, 63 was the common age, 51% predominantly male, comorbidities being predominantly diabetes, and acute kidney injury was seen in 7%, which was, and landed up with severe disease were 41% with an average stay of 22 days. This all had led to a hospital mortality of as high as 14% and 72% mortality in patients with pre-existing acute kidney injury. So I think with COVID also here, we've got another phantom that we've got to fight, and acute kidney injury with COVID is extremely common and leads to a good amount of hospital mortality and morbidity.
Okay, thank you. So we can conclude that patients with COVID, with severe COVID, as well as a concomitant acute kidney injury, they have more than almost 5 times more probability to have a worse outcome. So we can conclude that. So it's an and we have gone that. So my question to Dr. Rishi would be that who are the persons at risk of obviously the hospitalized patients to have an acute kidney injury? So that means these people have not come to a hospital for kidney problems, but with some other comorbidities, and then eventually developing a kidney problem. So who are at risk?
Right. So thanks, Dr. Arindam. Maybe have the next slide, please. So when we talk of risk factors for acute kidney injury, so these are what the patients who we need to identify in the triage when we see them for the first time, any of us, to know what is the risk of this patient developing an acute kidney injury while in the hospital stay. They may have come for any reason to the hospital. So some of these risk factors are modifiable and some of them are non-modifiable. Non-modifiable is somebody like an older age patient and with, say, peripheral vascular disease or diabetes, or the patient already has a chronic liver disease, chronic heart failure, or maybe having something like an AIDS or a prior kidney surgery or renal artery stenosis, so some structural illness, which is a non-modifiable thing. Or they could come with some factors which are modifiable. If we pay attention to them, we should be able to help them more. What would those be? The most important is the one at the bottom, which is sepsis. And untreated sepsis or late treatment of sepsis would be a severe risk factor, modifiable. In addition to that, any patient coming to the hospital with a low hemoglobin, severe anemia, hypertension, low albumin, low serum sodium, uh, patient has already taken some nephrotoxic drugs for some pains en route to the hospital. These are the patients who will be at a higher risk of developing worsening acute kidney injury during their hospital stay.
And can you, sir, also give us a little quick classification? Most of our delegates and viewers already know very quick etiology of your acute renal failure or acute kidney injury.
So this is a slide I have been showing this August group for the last 15 years, that and all my students who go through a training program with me, whenever you look at acute kidney injury, acute renal failure as we used to call it before, it's basically only three causes. It's either before the kidney, which means pre-renal, it is inside the kidney, which means intrarenal or intrinsic, or it's a post-renal. Post-renals are usually of a surgical nature, some form of obstruction to the urinary system. Intrarenals are those, it's a very busy slide, difficult to go through, but basically intrarenal are those which are primarily kidney disease. They could be glomerular, tubular, interstitial, vascular, but they are intrarenal. And prerenal are those which are prior to the kidney. They would fall mostly in the group of modifiable risk factors, dehydration, volume losses, blood loss. All of them would fall in the pre-renal group. And some of them which we mentioned, pre-existing, say a patient has pre-existing heart condition, chronic heart failure, and taken an NSAID. Now that would be a pre-renal for sure.
So if we can very quickly summarize the commonest causes, the pre-renal would be either a sepsis or a volume depletion. Post-renal would be primarily obstruction, sir. And it would be a combination of problem in the glomerules or the tubules or in the interstitium, right?
Absolutely. Absolutely.
So, and obviously, we need to diagnose it pretty quickly and precisely so that our objective and structured treatment towards the etiology will be different and will be. So I will come to Dr. Darshana. Is that, can you give a little brief outline of management, that how we actually do manage in different.
So for a management of acute kidney injury, the very first important part of the management is the diagnosis. And the diagnosis is by taking a history, by going into the details, as well as in the hospitalized patients. It's also on seeing on the changing spectrum of the daily examination that we see, and we have to assess many things like the hemodynamics, which includes the tachycardia or the hypotension that we come across. And if a patient is hypertensive and if he develops a blood pressure of around 100 or 120, it is significant for that patient. So those things are the things which we need to check, and also the urinary output that we have to monitor, because that is one of the initial markers which we come to know, where the patient is going to go ahead for acute kidney injury. And in addition to this, we do the lab markers, and we keep a very close watch on the patients who are on either any nephrotoxic drugs, if patients have decreased oral intake, if patients are in sepsis, so, and if patients are on painkiller medication. So those, and the age groups which already Dr. Rishi has already described, and patients with a background of hypertension or diabetes mellitus who need to be having a close watch on their blood sugars, whether they are developing ketosis and all that. So basically it starts with a history taking, going into the depth of the examination, monitoring on a clinical basis the daily examination, keeping a watch on the vitals and the intake output. And this will be associated in collaboration with the labs that we keep a check on.
Dr. Mehul, you want to add on something on the specific management once you diagnose and once you have monitored? Mehul, you are inaudible. You have to unmute yourself.
Sorry. Can you hear me?
Yes.
Yes. So besides what Dr. Darshana also said, is there a very important clinical aspect about acute kidney injury management. And besides, with the history, with the examination, with the bedside, which is always going to be not replaceable, labs also play an important point. And then ultimately comes when you classify your kidney injury as whether they are pre-renal, intrinsic, or post-renal. Importantly, it's important to know that some of these patients who do come in with a lot of sepsis and then have a ureteric stone or a post-renal obstruction, then it's important to identify these type of patients, get their scans done, and then do a primary source control. So basically, when we talk, we look at the causes. If it is a prerenal situation, then you need to hydrate them adequately, volume load them. As Dr. Darshana said, maintain their mean arterial pressures and make sure that we're avoiding all nephrotoxic agents, and then treat the underlying causes, maintain, monitor. Acid-base balance then tends to be an important factor, which then gets altered, and we need to make sure that that is maintained. And then look at the way the kidney functions are improving or deteriorating. There are advanced modalities of management of these patients. And
we'll come to that later on specific management.
Dialysis, leave that for the yes.
So I can take a little liberty from Dr. Rushi and can say that if you see the pre-renal, that is an area where the intensivist as well as the physician will play a major role, right, to prevent and to correct the volume. In the post-renal part, it is mostly the relieving of obstruction, where the neurosurgical role would be much a, and the intrinsic renal disease, where a nephrologist will obviously predominantly play a role to relieve the tubular, interstitial, or glomerular problems. So we can simplify in that way. Okay. And Dr. Rushi, how is AKI affects the pharmacology aspect of a patient?
Well, I would think of this in two ways. One is I would think about the drugs that may have led to the AKI. And I think you're just showing the slide up there. Thanks for that. These are the common medicines which are used in clinical practice, which are important in their own way, but some of them lead to an acute kidney injury, usually because of an acute tubular necrosis. So the common ones in our practice are the aminoglycosides, which are great antibiotics, NSAIDs, and the pain medicines, drugs which we actually use so much, ACE inhibitors and ARBs, and they could become a villain in case of prerenal AKI. Amphotericin, I mean, when it's needed, it's needed. And then some malignancy drugs like cisplatin. Of course, our contrast, which has become an integral part of our imaging techniques in CT-guided procedures, it's a nephrotoxic drug. And other medicines, which are kind of finding more and more use, like zoledronate in osteoporosis and whatnot. So there are a lot of medicines. This list cannot be all inclusive, but there are so many medicines which are associated with an acute kidney injury.
So I have a very quick question for you.
Yeah.
Are most of these cause are reversible, Etienne?
Yeah. So see, whenever we are talking about a drug-induced AKI, if you're able to diagnose it before it becomes too bad, yes, it is totally reversible. So the key here, Dr. Arindam, and thanks for the question. The key here is to diagnose early, and that is where I think this whole program and our AKI pathway comes in, which I'm sure you'll be explaining more to the audience.
Okay, and anything that medications which
now this is very important, and this is something which is often forgotten. Dose adjustment in acute kidney injury. So creatinine, the way we like to monitor our kidney function on a regular basis, eGFRs that we are going to use in every single patient of ours to assess the drug dose. And this adjustment could even happen like twice a day in some patients. Mostly it will be happening once a day, but some patients even twice a day may be needed. And there are so many pharmacokinetic and pharmacodynamic effects of each drug in the prescription that we will have to go through to understand what kind of dose adjustment you need. There could be a drug which is very lipid soluble, like say digoxin, which will have a very different adjustment to some more water soluble drug that we are talking about. So there are lots of factors that will be considered. You have given a few examples on the screen, but I will not go through the details of them in the interest of time. But suffice to say that dose adjustment for drugs is an integral part of critical care nephrology.
So this would be a service which would be very heavily provided by the department itself. Okay. And I'm taking the clue that how can we diagnose early to prevent a development of AKI? Are there any biomarkers there to predict? So I put it through Dr. Darshana to take the first one, that early diagnosis. And how do we do an early diagnosis? Sort of a preemptive diagnosis of AKI, even if before it happens.
For Dr. Arindam, just on the next slide, please.
Yeah.
So basically, if a patient is presenting with acute kidney injury, there is a progressive increase in the blood urea nitrogen and the creatinine levels, which we, and in addition, we also take the history and the physical examination that we do, obtain the other markers that are there. We also check electrolytes, potassium, lactate, all those things. We'll see if the patient, after taking the history and sending for the samples, if the patient has got any oliguria. Now, oliguria, we have to keep a check on the intake and output, which will be a very important part. And if there is any oliguria, then we need to keep a close monitoring and check out on certain factors that can cause, and which we already said in the previous slides also, we have to divide it into pre-renal as well as if there is any obstructive pathology. If it is a pre-renal, then you again check on the volume depletion, check for the ketones, and check for the acidosis, which we can very easily get nowadays on the point of care, which is through ABG also. We can get the lactates also, which also help us. Check for any volume depletion in the form of congestive heart failures, check for IVC that we can check at the bedside, which is also one of the things which helps us in
mostly on the volume, sepsis, electrolytes, and all others. I will very quickly to Dr. Rushi, is that the role of ultrasound and urine analysis, particularly microscopic analysis of urine. Very quickly, sir.
Dr. Arindam, I mean, I've said this umpteen times and I don't hate to repeat it. Urine is yellow because it contains gold. It is a wealth of information and not the physical gold that people crave for. So urine microscopy done carefully can give us a lot of indicators as to what kind of a kidney injury you are dealing with, whether it's a pre-renal or an intrarenal, depending on the cells we see, depending on the cast, depending on the urinary osmolarity, urinary sodium, which we so commonly use in our practice now. A lot of information can be gained in helping early diagnosis of this kidney injury. And like I always say, the first indicator other than your biochemistry, the earlier one is actually a timed urinary output. I mean, a timed urinary creatinine clearance is the best gauge for any GFR in our ICU patients.
So we can conclude that the volume as well as a detailed microscopic examination can actually precede or preempt a diagnosis of AKI itself.
Yes, and of course the ultrasound that you mentioned in your question, which I did not refer to, a simple screening ultrasound to rule out an obstruction and to define that anatomically the kidneys are looking normal is a very important thing to diagnose an acute kidney injury. Sometimes small shrunken kidneys masquerading as an AKI is something we don't want. We want that to be picked up very early before we diagnose the patient.
Okay, and quickly, Dr. Mehul, you have practiced in many different parts of the world. And do you think there is a role of biomarkers, just like the analogy of use of biomarkers in acute myocardial infarction? So do you think there's a role of biomarkers to preempt diagnosis of AKI?
Most definitely. I think that by the time we have a rise of creatinine, which is going visibly more than 1.5 times the normal, or you see a rise of creatinine, I think we've already missed the bus. And if you look at this slide, it clearly shows you that by the time you had a rise of creatinine, you've really developed cell death, apoptosis, necrosis. There are a lot of biomarkers which have been studied, a lot of biomarkers which get released at the time of ischemia, reperfusion injury, toxicity, which lead to damages of the renal tubules. Some of them are ND-GAL, IL-18, and some of these microalbumin urea, cystatin C levels. Some of these biomarkers are very helpful, like we look at procalcitonin, which is a commonly understandable biomarker which we are studying in sepsis. These biomarkers will help us out to identify these patients who have an increased risk developing a damage of decreasing the GFR, progressing towards acute kidney injury.
And to help us, I think these are available both in the labs as well as point of care testing, right? And it can
That's
be
right, absolutely right.
serum and urine. So just like how we do a bedside testing to rule out acute coronary syndrome, we do a TROP-I or TROP-T at the bedside event. We can do a NGAL or cystatin C, particularly at the bedside, with a basic urine sample also, just to stratify that this patient is at higher risk to develop an AKI in subsequent time unless we intervene, right? Okay, so some quick recommendation, Rushi said, on prevention of kidney injury or prevention.
So basically, this is like summarizing so far in the initial part of your talk, Dr. Anandam, the presentation we are doing. So basically, it all boils down to the again the AKI pathway which we'll be talking about is the early pickups, early diagnosis of acute kidney injury, and the simple clinical tools like creatinine, urine output, which will be used at the point of care. In addition, sophisticated tools that we showed, with whether it's an ultrasound, urine, these new biomarkers which are available with us, whatever we are using to early diagnosis. Once also, by no means the basics of medicine can be forgotten. Asking for the right medicines, the history, and making sure whether all critical factors have been ruled out, managing their fluid balances absolutely carefully, deciding which one of them, the cause of the AKI, and once you have narrowed down on the cause of the AKI, then the treatment of the particular cause with a proper specific agent is the way to go forward.
Thank you, sir. Okay, so let's move towards little a. I would repeat in this one. Mehul and Darshana, if Darshana can please take the renal indications of your dialysis or RRT, what we call renal replacement therapy, done for kidney problems.
Sure. Can you go to the next slide, please?
Yes.
So there are definitely the indications for the renal replacement therapy. We first try with the patient's treatment with whatever medical measures that we can. But then if the condition is worsening in the form of anuria, where it is a negligible urine output for almost 6 hours, hyperkalemia, not correctable with whatever is the potassium corrections that we give. And even we have to keep a check on the evidence on the electrocardiogram, which we see on the monitor, which is seen easily. Any kind of poisoning or intoxication is one part where we cannot wait. We have to even do it as a preventive measure. Pronounced azotemia, where the urea nitrogen concentration is more than 84 milligram per DL, along with the drowsiness, which is there. Severe metabolic acidosis, despite normal or low partial pressure of carbon dioxide in arterial blood, where we get a pH of less than 7.2. Severe oliguria, urine output less than 200 ml over 12 hours. Any uremic complications which we come across, one of the most complications that we come across in these patients are encephalopathy. And we see that after a dialysis, this patient show improvement in the consciousness level. Neuropathies or pericarditis and volume overload like pulmonary edema, which is unresponsive to diuretics. We see that these patients have to, instead of going on a ventilator, we can just do small things like scuff, where we only remove the ultrafiltration and help them in in getting better. Definitely. And not requiring a ventilator.
Just to summarize how I was taught by the nephrology seniors, that you remember the vowels, A, E, I, O, U, acidosis, electrolyte imbalance, intoxication, I, O, uremic symptoms, right? This is, Rushi sir is laughing and that smiling on this part. So this is very easy way to remember. Okay, Mehul, quickly, renal replacement therapy for non-kidney disease.
Yes. So an important aspect, people, I do not know whether we are aware of it, but dialysis is always in the society associated with only kidney damages. But yes, as we support organs, kidney support is a very important thing which we need to realize. And there are non-renal indications for doing this. There are a lot of extracorporeal reasons of doing dialysis. You have things like a continuous renal replacement therapy. It's a facility which is provided at the bedside of the patients who are hemodynamically unstable, cannot be even moved to a dialysis center or a dialysis unit, or they are so precariously on high blood pressure supporting medications that it is very imperative that they cannot have a lot of volume removed. So you do the same dialysis, but you do the dialysis over a long period of time. Indications of these would be, as on the screen, tumor lysis, severe lactic acidosis, a lot of metabolic acidosis, thermal injuries, patients with severe hypothermia, sepsis, and SIRS. When you see a lot of these patients coming in with a massive cytokine storm, we'll show you down the line and how we're doing it. There are a lot of these type of filters which help to remove a certain molecular weight of substances, likely what everybody has heard, the fashion of the IL-6. So there are, like IL-6, there are n number of
We'll actually come to that
molecules.
part, actually, the cytokine removals. We have a separate day. Rushi said, do you want to add other indications like your neurological problems, like your myasthenia and others? Where we
See, basically, what I will add to what Dr. Darshan and Dr. Mehul has summarized so aptly, that when it's indication for renal causes, dialyze whenever in doubt. That's what I was taught. So never wait for an absolute indication to come up. Dialyze early and your patients do much better. There is enough evidence everywhere now that we need not wait for any absolute indication. It is a very safe modality to initiate early for the patient's benefit, and dialysis for renal indication should be initiated before absolute indication super early. For non-renal indications, the spectrum is actually widening further, and dialysis and dialysis machines primarily as a support are as a base are helping do so many non-renal indications. And these are what Mehul said is primarily using dialysis as a modality with a dialysis machine for non-renal indications. And you could be doing different things like plasma exchange with the same machine, and that would be very helpful in your, say, good pastures or myasthenia gravis. There's so many other antibody-mediated diseases like lupus and complications of that. You will be doing plasma exchanges with the same machine, and I'm sure you're going to talk about that.
Yes, sir. We'll come down in the because before that, I would like our panelists to give a little overview of the different modalities of renal replacement therapy, right? So we all know this is how the dialysis, the proper dialysis happens, right? Hemodialysis. It is mostly a diffusion from according to the concentration gradient through a semi-permeable membrane, wherein filtration, this is across the pressure, where there is a movement of the solvent which drags the solute itself, right? So we call it a solvent drag, which becomes a convection or a filtration. So when we do this is called a filtration, and when we do this, the diffusion process best, it's called a dialysis. So, and when we mix both of them, we call it a diafiltration. So mostly we do dialysis on an intermittent basis, but when you are using a prolonged or a continuous, I think it is better to use a diafiltration, right? So I'm not going into this detail. I would ask our nephrology sir to just give an idea that what is an intermittent, what is an hybrid, and what is a continuous, and where these are applicable. Sir, very quickly.
Thank you, Dr. Arindam. So basically, like you aptly summarized, it brings us to the basics of physics. What is diffusion? What is convection? What is ultrafiltration, etc. But when we are using these technologies in the ICU, I mean, all of you with so many of your patients, you have heard that patient was in IHD, intermittent hemodialysis, or patient was on SLED. That's the term, right? Slow, low efficiency dialysis. Or patient was on CRRT, continuous renal replacement therapy. And these are the detailing of all these three modalities which we have available in the hospital to support the patient according to his or her own need. Suppose the patient is very stable, you might end up just on an intermittent dialysis. Particularly, these are patients who are already on dialysis who have come in for other problems, and they end up usually on some intermittent dialysis 3 or 4 times a week, 4-hour sessions, because that does the need. So it's need based. What is the need? The need for removing extra volume, the need for removing extra, the urea, creatinine, acidosis, electrolyte based balance. So all of them, if they can be satisfied, you can go with intermittent. SLED is for hemodynamically like unstable patients where you need a prolonged dialysis, 8 hours, 6 hours, 10 hours, depending on the duration we employ, where we can actually do the same process slowly with lower blood flows, and that helps us in better hemodynamic management of these patients. And even more sick patients who can't even tolerate the SLED via CRRT, and we usually do a CVVHD or a CVVHDF for these patients. and wherein, suppose, it's a simple example. Suppose I need to remove 1 liter of fluid in a patient. In intermittent hemodialysis, I'm removing within 4 hours. That is 250 ml per hour. When I go for a SLED, 8 hours, I'm removing 125 ml per hour. When I'm doing CRRT on the same patient, I'm removing 40 ml per hour. Because over 24 hours, it will be 960.
So we can summarize in that way that if you have a very stable blood pressure patient, right, and
Yeah.
no other contraindication, we can go for intermittent because it finishes up in 3-4 hours time and the cost is minimal. If we have a very sick patient, right, and along with the blood pressures are almost not there, with liver failure, a brain injury, high intracerebral pressure, we should go for CRRT. And in between patients who are little unstable and you require a prolonged sort of therapy, so SLED is the choice. And I think most of the nephrologists all over the world is now preferring SLED for ICU patients. It's a best of both worlds, right? Sir, I just need a clarification very quickly. This low efficiency, right? A lot of people think that the efficiency is not enough efficient. Can you please explain this misnomer?
So it is not about the efficiency of the dialysis going down. It is like if 4 hours of SLED compared to 4 hours of intermittent dialysis, there you will call it low efficient. But when
So
you
low
make a
efficiency of solute removals mostly.
yes,
And
you're
the
talking.
time required to do that.
So if you're extending the time, you're covering for the low efficiency and you induce the low efficiency to maintain the hemodynamic stability. So this was by choice.
Okay, I will come to Mehul. You have a good experience on CRRT both in India and Australia, right? So give us 2 good points and 2 not so good points on CRRT. And who are the actual ideal candidates for CRRT? Absolute indication.
So, patients who've been hemodynamically very unstable, all right, these are the ones who will be the best candidate for CRRTs. And the downside for CRRT, at least in India, is unfortunately the cost factor. I find CRRT as a very well controlled modality. There is an important thing for us as an intensivist that a lot of dosages need to be altered being on CRRT. That part of the study or that part of not been so well understood. But yes, these are things which are in evolution and there are some amount of fixed guidelines which are coming up. But yes, CRRT for patients who are hemodynamically unstable, classically the ones who are in severe sepsis and septic shock, will be a good candidate or the most important candidate for CRRT. The other indications that we've used in the recent times, we're coming out with some publications also on it, is we've used CRRT with filtration cartridges for COVID patients also.
Okay. And I will come to Dr. Darshana very quickly, that where does you think that the SLED scores over and should be used? Very quickly.
SLED is scored over in patients who are having hypotension and where there is a need of removing these toxins. And we know that this patient's acidosis and the hyperkalemia needs to be improved, but they are on massive vasopressor supports. There is the situation where we use SLED.
Okay. So I will come to NA. Dr. Rushi, if you can give us a little quicker review of the other hybrid therapies like high volume hemofiltration or coupled plasma filtration like that. Very quickly, sir.
So see, basically, for the audience, I would like to say this, that this is not to kind of, so these concepts are new and in evolution. So when you talk of diafiltration or when you talk of hemofiltration, this is, not, it's a concept where you're basically using more convective clearance for better removal of middle molecules during the dialysis session. So, middle molecules, molecular weight in the middle range, which cannot be removed by the dialysis technique alone, can be removed when you do a hemofiltration. Particularly in patients with sepsis, these cytokines which Mehul so aptly mentioned, the molecular weight of these cytokines comes in the middle molecular range. So this was actually old data from Italy where they had clearly shown, one of the founders of the concept of critical care nephrology, Dr. Ronco, So they clearly showed that high volume ultra hemofiltration is beneficial in sepsis. That was one of the first studies that came out. And of course, when you add plasma filtration with adsorption, there are different types which I'm sure we are going to talk about. But these are adsorptive techniques. What is adsorption and what is absorption? All of you are aware. So adsorption means sticking to the surface, simply put. So when you put a filter, which is a sticky surface, and that is going to bind. Sorry, Arindam. So basically, I think that's we can maybe Mehul and Darshana can also add on because we have used quite a number of these filters recently.
So we are actually running out of time. So I think we should now concentrate on the services that what we can do with the critical care nephrology and who can benefit out of it. So I will ask Mehul to start and then the other. Dr. Anil, I will take another 2-3 minutes to sum it up. Dr. Mehul, very quickly.
You have 10 minutes more.
We Arindam.
Oh, 10 minutes more.
10 minutes more.
Yeah, we have 10 minutes.
Oh, fair enough. Fair enough. So then I will place it accordingly. I will go into the other part of that. Then this part is very important. That can we improve outcome of sepsis or SIRS by applying specialized dialytic methods? Mehul and Darshana, you both can choose to answer this. I think.
Mehul, you can go ahead. I know you have. Hello.
Sorry, I was mute. So we are all using a lot of these new filters. Thanks, Arvindam, for sharing the slides. There are a lot of these filters, and as Dr. Rishi was explaining, and what Dr. Arvindam was trying to put forward is the basic physics, is that you have patients with toxins, poisoning, you have patients with inborn error of metabolisms, you've got patients who've got sepsis. Basically, what you're doing is you're using a higher surface area. The concept of these filters is that it has such a high surface area. You will be surprised if I tell you that one of the filters has an area, or a lot of them have an area as big as 4 times a football field. So these are polymeric beads which are put across, and these basically improve the surface area for adsorption. And hence, we will show you in some of these slides how these molecules, which are the culprit for the problem, may be cytokine storm that leads to organ dysfunction, ending up and culminating into multi-organ dysfunction. We've got endotoxemia. So we've come out with endotoxin assays, and with these assays, you are able to use the right filter. Unfortunately, a lot of the commercial filters are available. Problem is, a lot of them, people do not know which filter to use where. So you've got a lot of these different filters, which are also FDA approved. Like you just saw, Toramixin filter is there, Cytosop filters are there. These filters are there, and they used at specific indications, may it be endotoxemia, may it be cytokine storm. You may have a cytokine storm even in sepsis. You may have a cytokine storm in acute pancreatitis. You may have a cytokine storm in severe autoimmune hepatitis or an autoimmune situation. There are broadening indications, as Dr. Rishi was pointing out, for the use of these type of filters in critical care, which is an evolution, and hence critical care nephrology is here to stay and is a new kid on the block, and is very important for us to understand that dialysis is not only limited to kidney patients. In the intensive care, the spectrum of dialysis has broadened. Yes, Arvindam.
And Darshana, would you like to summarize a little bit on your experience and our experience in HN Reliance?
Yeah, in HN Reliance, we have had many patients whom in the non-kidney injury patients, we have used these modalities. And one of the advantages also is that this can be also used in patients who are on ECMO, in patients of sepsis, and we have used these filters and we have got good results with this. So it's been an experience which we have come across, and we have been successful in most of our patients. We have seen even Mehul, one of the young patients, we had seen the interleukin levels have dropped down in 24 hours, if I'm not mistaken, right?
Yeah.
Yes. Yes.
Okay, then I will come to the next question, which Dr. Rushi was talking, because you must get a lot of referrals as a nephrologist. Now you will get a lot of referrals as a critical care nephrologist for using some specialized dialytic methods to remove toxins and drug overdose. Sir, your experience on that?
Yeah, absolutely. So, we want to develop this program and one of the points of developing this program is to make it a center of excellence for management of poisonings. Because, these poisonings, I mean, whenever we talk about basics of poisonings, all of us know how to manage them. But coming to the specifics, the poisons which are dissolved inside, how can they be removed out? So the techniques that we can use for removing these toxins, the continuous hemodiafiltration, renal replacement therapy, coupled with plasma exchange, hemoperfusion columns using charcoal and other adsorption techniques. So these are the different modalities which can be used to basically remove the extra corporeal toxins which are part of the patient after he has taken them accidentally or whichever way. And our city really needs a center for poisoning care, where these poisoning patients with accidental or intentional poisonings can be properly managed, and dialysis technologies can help management of poisonings in a big way.
Right. So our understanding is that some of the poisons like this one, Rushi said, can be easily removed by a simple dialysis because their molecular size or their the charge and all others, they can be easily removed by dialysis. But most of the common toxins and drugs are difficult to be removed by standard dialytic methods, and there we apply some specific specialized techniques. Mehul, your experience on charcoal or standard hemoperfusion or something else, plasmapheresis like that, very quickly.
Yes. So we've used a good amount of plasmapheresis, especially when you've got patients who are in severe sepsis, and then we've landed up with things like TTP and are having a lot of schistocytes, and then they're going into multi-organ failure. Patients who've been on, besides the poisoning, the ones who've been in hepatic coma, and these are the ones which we've used.
And regarding your drug overdose or toxins, because our idea of doing charcoal hemoperfusion or plasma exchange for toxin removals are actually applicable to those toxins which are very highly protein bound, right? Because they are not amenable to standard dialytic therapy removal. So we do it. So your experience.
Yeah. So we've used in like cases like when you have paraquat poisoning or organophosphate poisoning, carbamazepine overtoxicity. These are the ones. Even surprisingly, when we don't see it much often now with theophylline toxicities. So these are the ones where charcoal hemoperfusion has been well established and can be used.
Dr. Rushi, you want to comment something?
No, I said our couple of patients with barbiturate overdose and digoxin poisonings who have actually improved with all these mixed modalities.
So the message that we can put across is that previously the notion was that very few drugs can be dialyzed, and right now with the different kinds of filters, techniques, absorption, exchange, all those things, we can almost possibly take out any drug from the body itself. Do you agree on that part, Rushi, Mehul, and Darshana ji?
It is a significant advance. I mean, we can't say a blanket, but yes, it will go a long way in helping patient care with poisonings.
Okay, thank you, sir. And coming to Mehul, say that the other conditions which might be or probably be treated by a modification of renal replacement therapy. You were talking about liver failure and hepatic encephalopathy, right? So where you can do a little bit of where it removes the cytokines. I can remember Darshana speaking about the refractory heart failure, where an isolated ultrafiltration, maybe a slow continuous ultrafiltration, a lot of times not very liked by the cardiology people but this is a modality which can be used for refractory volume overload. The common thing I have seen a lot in North India is rhabdomyolysis, particularly removal of myoglobin. Rushi sir, any comment?
Oh, absolutely. So basically, the indications that you are showing are very relevant to RFH, which is a multi-organ transplant center. The reason why cardiologists were not very receptive to the idea of SCUF or slow continuous ultrafiltration is because it was a bridge to transplant. And if you don't have heart transplant, what's the advantage of doing that?
Right.
Same thing for charcoal hemoperfusion for your liver, what Mehul was alluding to. Since RFH is a center of excellence for heart transplant, lung transplant, liver transplant, having these modalities with us actually helps us to bridge the patient till the time that they get the organs.
So
And if
we
set up,
this
they are
this
very
modal,
well.
sir, you are implying that these modalities will buy time for our patients who are waiting for transplants, which the organs which are not easily available or only available in cadaveric donation, as well as it will also improve the outcome of the subsequent transplant because you are optimizing the patient too.
Absolutely correct. So this critical care nephrology will be a backbone service for all the multi-organ transplants that will be done at RFH.
And you do a lot of oncology also. I'm a new joinee of this, but in only 1 month, I have seen a lot of oncology, both surgical and medical. So, Dr. Darshana, do you think it is also a good option for a tumor lysis syndrome if it happens? We take
Yes, yes, it is. It is a very important aspect. We have a lot of oncology patients who come over here, and we see that these patients where they have very high uric acid and all those phosphate levels as well as the calcium levels, and they are in severe tumor lysis. And this is the patient where we should, in fact, immediately start the patient on one of these modes of RRT, which makes a very fast recovery and again avoids requiring other support systems like the ventilator and the other supports that are required in these patients.
And
So
obviously also the hypercalcemia, lactic
hypercalcemia is one of
acidosis, right?
because yeah,
Right.
that is one of the things which we see in our onco patients very commonly.
Okay, and lastly, and how we have integrated all these therapies. Mehul and Rusi sir, very quickly on the most.
See, basically, it is like all the organs are talking to each other in the body. So this crosstalk is what is the basis of most of multi-organ support therapy. And like we said, the illness of the organs may be a transient one or a permanent one. If it's a transient one, then with the dialysis technologies that we all went through, it's a cure for the patient. And if it's an illness which cannot be removed, it's a permanent thing, and then these treatments will serve as a bridge to definitive treatment like organ replacement. So most, this is a concept which is picking up more and more, and different organ supports. And if you are able to support your vital organs, you are able to buy the critical thing which all patients need in the ICU, and that is time. Because once they have time, they can heal.
Mehul, do you want to comment?
Yes. So, besides the time where we've used a lot of extracorporeal circulations, we've used it on ECMO. So you have patients who've been on ECMO, on whom we've used renal replacement therapy or extended sleds. So our services do not only end up with dialysis and with CRRT, even in transplant patients, even on patients on ECMO, dialysis and CRRT seems to be a very well established role with a very good positive outcomes, especially in these patients with heart transplant and being on ECMO.
If all of you allow me, so I can conclude this one as that HN Reliance has got all the facilities to support a patient, right? Who have a kidney problem, who have a heart problem, need ultrafiltration, who have all the sepsis or SARS, who need specified cytokine or toxin removal therapy. Even if the patient needs lung and heart support, we have all sort of VV, VA, ECMO, and your LVADs and all this mechanical cardiac support. And even if the patient needs eventually any bridge to transplantation and that, so we can support that. So it's a complete comprehensive 360-degree support starting from critical care nephrology and subsequent definitive therapy. Can we conclude that? Rushi sir?
Absolutely in agreement with you, Arindam.
Okay, so coming to this almost ending of this part, so I would come to the purpose of critical care nephrology, with Dr. Rushi said. Mehul, very quickly, the services that we would be providing in critical care nephrology. And
yes, thank you. Can I?
Yes, and then I will come to Rushi sir, who will conclude that how things will work, what is a pathway, AKI pathway.
I need to share my screen. So if I'm being able to allow to share my screen, not allowed to share my screen.
I don't know, you'll have to sign off for you to share the screen.
I would do the stop sharing.
No, not yet. Okay, I think yes. Yes. I've got it. All right. So the services in critical care nephrology, and I'm leaving it open for everyone, any of all of my panelists to help me out over here. But this is what we are putting forward. So preventive is what we look at. As you know, the patient enters the hospital. From the time he enters the hospital, from the triage, we will be able to offer a service through our team with regards to identifying, monitoring, and screening these patients. But preventive services, what we will look at is when you have patients coming in who are referred to us, who are undergoing major surgeries in a perioperative period, in order to prevent or to eliminate the risk of them landing up in acute kidney injury. All medical patients with high risk, like diabetes, like hypertension, like pre-existing renal dysfunction, patients who are undergoing any interventional radiological procedures, very importantly with dyes, with the way that these dyes are used and with the hydration and with the risk factors of the patient. Oncology and the therapies, chemotherapy or any other therapy given along with these oncology patients who also have a very high risk of developing acute kidney injury and renal dysfunction, and therapies with potential nephrotoxicity, which sometimes are unaware. We will be able to highlight it, prevent it. So preventive is one of the first keystone what we are trying to aim at. Then comes the diagnostic. As we saw, early diagnosis with the use of these biomarkers, which will help us not only to wait for 24 hours before the creatinine rises or the patient lands up with having a deranged renal function. With the use of routine biochemistries and cytologies, we'll be able to put in our heads together and identify these patients who are going to be at risk using basic and advanced imaging techniques. As we saw, histopathological variations and histopathological is a good aid to help us out to identify patients who are going to be at risk of developing acute kidney injury or who are having an established kidney injury, unable to being able to pick it up or getting it diagnosed. And lastly, patients who with the use of studies like nuclear scans, DTPAs and angiograms, we use diagnostic modalities to aid our services. Ultimately, we come to a curative point of view. Standard dialysate therapy, everybody is aware, the use of multiple modalities of dialysis, not only with the routine intermittent hemodialysis, we talk about SCUF, extended SCUF, SLEDs. These are new modalities of dialysis. And then you all heard about CRRT, that is continuous renal replacement therapies. These are a part of hybrid therapies which are used. Certain types of CRRTs, which different hybrid filters, which help in patients with cytokine storm, septic shock, endotoxemia, poisoning, hepatic coma, lactic acidosis, and metabolic abnormalities, and removal of substances with the use of these extracorporeal filters. Even such situations where we are using it on ECMO, we'll be able to help. Lastly, multi-organ support, as we all have seen, is another strong modality of support with critical care nephrology. We come to supportive role of management in critical care nephrology. Besides the fluid electrolyte and correction of these, making sure that these are monitored on a day-to-day basis, dosages of drugs, modification of the dosages of drugs, and informing the consultant with regards to the modifications of these, monitoring these patients on a day-to-day basis, and bringing it up to the notice that these patients may be going into use of pharmaconutritional interventions, important aspect which is very highly neglected and something which is a new thing which is coming up, and organ crosstalk as what we've been putting forward. Lastly, we have things which are about rehabilitation with renal replacement therapy, weaning from when are these patients going to be fit, capable of weaning off from renal replacement therapy. We've got comprehensive rehabilitation programs prepared by us, counseling session of patients with regards to CRRT and with regards to renal replacement therapy for patients, meticulous follow-up of these patients, and lastly and most importantly, awareness, education of the society and of our fellow colleagues towards a thing which is critical care nephrology, which is a very important new concept which we like to put forward. I'll leave it to Rishi to end.
Rishi sir, please conclude the session.
Sure. Thank you so much. Yeah, thank you so much, Dr. Arindam, Dr. Mehul, Dr. Darshana. See, basically, the idea where came up with developing critical care nephrology at Reliance Foundation Hospital was because of the support from the management and the trustees and everybody. The important thing here is we have all the infrastructure that is possibly required anywhere in the world to run this program. Rightly, what Mehul showed, right from picking them early to giving them the best service to curing them. This is a service not only for your kidney patients who will be coming to the hospital, but for every patient who will be coming to the hospital for a critical illness, whether it's a major surgery, whether it is chemo care, whether whatever, organ transplant, they are all going to be helped by this service which will be offered in the hospital. And not just that, we are going to follow them in a rehabilitation where you are offering them the service to continue their recovery for. We want to develop this program and make it one of the best teaching centers in the country for critical care nephrology. That is our aim, and we would like to help to run this program properly to benefit maximum patients. And I really thank IMA for the kind invite today for us to come here today and as a team, introduce the concept of critical care nephrology, a new department which we are starting at Reliance Foundation Hospital. And thank you so much.
Thank you, sir.
Back to you, Dr. Jitesh. Dr. Anil.
बंद होगी अनिल नहीं ये खाली ये लाइट.
Yes, Dr. Anil Awad, please go ahead. If there are any questions to be taken or some conclude, whatever, according to time, you can tell us.
Thank you, sir. There are a few questions.
Okay, but I can.
Rishi, can I go with the questions?
Yeah, I can see certain.
There are a few questions. One is the role of
Mr.
GFR for AKI
Ramesh, Dr. Ramesh Thakkar said role of GFR for AKI.
Sir, basically, like we have always maintained, it should never be the creatinine value in isolation. It should always be the eGFR. And in our service, what we use is the time during GFR, where we measure the urine output for an hour or two and we calculate the GFR based on the actual creatinine excretion, which is a far better modality in patients with evolving AKI, because creatinine today and creatinine tomorrow, but the urine output is hourly. So you can pick it up much early. And what we show you here is prevention is cure. If you pick it early, you can cure. If you pick it up late, then you will have a much delayed course to recover.
I think the second question is on use of cytosorb in COVID-19.
Dr. Darshana and Mehul have really, they are the COVID warriors and they have done this at 7 Hills Hospital under the aegis of RFH. And I will ask them to take the question. Darshana, Mehul, please.
Sure. Darshana, if that's okay, I'll start. Yeah. So we've used a lot of these modalities, these filters, basically the use of removal of IL-6. Darshana was talking about one of the cases. We had a patient who had IL-6 levels of as high as 275,000. We've been publishing a couple of these reports with regards to the use of cytosorb in COVID patients. We were successful in treating this patient who had come in with COVID, with multi-organ dysfunction, and had IL-6 levels as high as 275, 76,000. There are a couple of other filters that are used, and cytosorb is one of the filters that does help in removing these cytokines. But the treatment modality is not purely only that; it is a multi-factorial way of managing the patient. It is an important key aspect, and there are Rishi was talking about an Italian trial which is coming out with it, and there are these Italian trials which are talking about the use of cytosorb and hemofiltration cartridges in severe COVID patients, especially with severe COVID pneumonia.
Darshana, anything to add?
Mehul has covered it very well. I don't need to, because even in the previous slides we have spoken about it.
So regarding use in GBS.
Oh, okay. So basically, plasma exchange is a standard in the treatment of GBS or Guillain-Barré syndrome, and it has been used for a long time. And that is something which we do routinely in our patients with GBS, and we have excellent outcomes. Excellent.
So both IVF and plasmapheresis are equally good, right? And it depends on the age. Maybe plasmapheresis is a little cheaper alternative to IVF.
So there are two things I would like to say in this regard. One is plasma exchange is relatively less expensive as compared to IVIG, and second is if at all patient does not recover with one modality and needs to go to the next, it is far better to do plasma exchange first and give IVIG later rather than the other way around.
Otherwise, all those IVIG would be filtered out if you do that way. Yeah.
So the other way, this is better to go with plasma.
And this plasmapheresis we have done in most of our patients of GBS over here, and even in the aged patients, they have tolerated it very well. Yeah. And that has been a good experience for us, where we are saving the cost of the IVIG, which is really a very costly therapy for these patients.
And also very importantly, the practicality of it, that you do a plasmapheresis, and if the patient doesn't improve, you have an option to go for IVIG next. But you don't have an option if you are going for an IVIG first, because when you use a plasmapheresis, it will filter out the IVIG that you have given. So 1 lakh goes in drain. Regarding your in hyperparathyroidism, I think repeated calcium spikes. So chelation or dialysis? Mehul, you want to take this one along with?
I think Rishi, you can take it. Rishi, go ahead. No problem. Go ahead.
So see, I mean, hyperparathyroidism, dialysis would be something that should not be needed. I mean, we should be able to manage this patient medically absolutely well. And it will only be in critical hypercalcemia that you might require a temporary dialysis session here and there. Otherwise, this is a modality which should be treated either medically or surgically, depending on the primary problem. If it's just,
So it could be used as a temporary measure in a life-threatening situation. We would require definitive therapy.
Emergency. Only hypercalcemic emergencies where time is of essence, you would want to go for dialysis. Otherwise, this is a case where you can avoid dialysis and still get the patient better.
Fair enough. Okay, I think we have completed the questions. No more questions. I would go back to the IMA administration. And thanks for giving us this opportunity to bring the nice panel discussion. And thanks all the panelists too.
Thank you.
Thank you, everybody.
And the whole team, Dr. Arindam Kar, Dr. Mehul Shah, Dr. Darshana Rathod, and Dr. Vivek. Yeah. It was an excellent presentation, and it was a nice idea by Dr. Rishi Deshpande to have such a program. Thank you very much, sir.
Thank you.
Actually, critical care nephrology is an emerging and challenging area in our field, and one that deserves attention. The new generation of nephrologists must be ready to collaborate with the intensivist to improve the care of the ICU patients, educate multidisciplinary teams, develop procedures and protocols, and perform basic and clinical research to better understand AKI pathophysiology. Thank you very much, Dr. Deshpande. And it was really a wonderful session because I'm getting phone calls from very many doctors that it was a wonderful session. Thank you very much.
Thank you so much. Thank you for the everything. Thank you.
Thank you.
Thank you, IMA.
Thank you, IMA. Thank you.
Friends, after this wonderful session on critical care nephrology, we are going to the World TB Day program, and we have a chairperson of World TB Day program, Dr. Suresh Doshi, and I hand over the proceedings to Dr. Suresh Doshi since he is the chairperson of the World TB Day. Over to Dr. Suresh Doshi.
Thank you very much, Dr. Anil Awad. And good morning, friends. Each year, we commemorate World TB Day on March 24th to raise public awareness about the devastating health, social and economic consequences of TB and to step up the efforts to end global TB epidemic. Friends, we celebrate World TB Day on 24th March as Dr. Robert Koch discovered TB germs. That's why. And the theme of the World TB Day 2021 is the clock is tickling. It conveys that the sense of the commitments to end TB made by the global leaders. This is especially critical in the context of the COVID-19 pandemic. Friends, IMA Mumbai branch has made a special video on TB control, which will be played now. So friends, today we have organized 2 lectures which will throw light on 2 deadly enemies of human lung, namely COVID-19 and TB. I have proud privilege to introduce Dr. Harish Chafle. Dr. Harish Chafle is a consultant intensivist, chest physician, bronchoscopist, and sleep disorder specialist at DNB Respiratory Medicine from National Board of Examination, New Delhi, IDCCM from Indian Society of Critical Care Medicine, DICC from Nagpur. He has a vast experience in conventional bronchoscopies and bronchoscopic interventions. He has expertise in his credit. He has written 2 chapters.
I guess there is technical glitch from sir's side.
No, actually, I'm there online.
No, sir, we can hear you and we can see you, but I guess Dr. Anil sir had some bandwidth issue.
Correct, correct. I think the voice was cracking in between.
Yes, yes. So I think we should continue, or else we can wait for 2 minutes for Dr. Sir to come. I guess
Should I
he'll be
start
back
sharing the screen or wait for them?
I think let's wait for 30 seconds.
Okay.
I guess he'll be joining soon.
Okay, okay.
Yes, Dr. Awad sir is joining. Dr. Awad sir.
हाँ सर स्टार्ट करा.
Yes.
Okay, okay.
सर सुन yes.
Yeah. Good morning, everyone who is attending this webinar, and I thank at the outset to all the IMA dignitaries and persons who are behind this conference since morning. It's a wonderful session ongoing. We just had a very good discussion about critical care nephrology, and as to celebrate the World TB Day, Dr. Doshi had given a very good theme song created by IMA. It was wonderful watching that, and thank you so much for the kind words of introduction for me. I'm Dr. Harish Chafle, practicing intensivist and chest physician in Global Hospital. So with those words, we start today's topic. And today's topic is very important, COVID and AMR. What is AMR? Is antimicrobial resistance. While working in ICU or prior AM or for working anywhere in the field of medical field, basically, first principle everyone has to follow is do no harm. So it comes true whenever you're treating any patient, it comes true whenever you're using any modality of treatment, and antibiotics is the most important modality of treatment for managing infectious diseases. And we are all facing the outmath of global COVID-19 pandemic, and we know it's a viral infection, but there is a general observation, and I would agree on that, that a lot of antibiotics have been used in this pandemic, and we are going to discuss about that and how we can avoid, how can we judiciously using the things, because if you are judicious in using things, I think we can save something for the future as well, as because we know we don't have many antibiotics in the pipeline for the next 10 years to come. We know how fast the vaccine was built up for COVID-19, and so we should be very careful. So AMR, the global challenge and the impact of COVID-19 on antibiotic resistance is what I'm going to discuss in these current headings. Secondary bacterial infections in viral pneumonia, azithromycin used in COVID-19 is a cause for concern. It predisposes to increasing resistance in Streptococcus pneumoniae, safety warnings with macrolides. expert warnings against macrolide use, unfavorable surveillance trends, position as WHO catches the antibiotic, WHO watch antibiotic, and impact on the microbiome, and then we'll take home messages as a conclusion of this lecture. So before we do that, AMR, the global challenge and the impact of COVID-19 on antibiotic resistance is what I want to bring to your notice. In recent years, we have seen an increasingly large number of headlines and articles detailing the rise in antimicrobial resistance, along with the dire consequences associated with it. These have appeared not just in scientific or medical journals, but also in the mainstream newspapers, news press. AMR, that is antimicrobial resistance, has for some years been recognized as one of the biggest threats to global public health because it will threaten our ability to treat even very common infections. Where antibiotics can be bought over the counter, the emergence and spread of resistance is made worse. So as we all know, our country is something where you can get over the counter anything and everything, right from antibiotics to painkillers to even certain toxic agents which are toxic and which are known to go into the toxidromes are also available over the counter. So this is the reality of situation in India. That's why we need to be more careful than people abroad who are using antibiotics while prescribing antibiotics. Without standard treatment guidelines, antibiotics are often overprescribed. That is the observation. Before proving something that it is because of if there is sepsis, if there is bacterial sepsis, if there is a viral infection, then we all know antiviral will be the drug of choice, but still we keep on writing antibiotics. Without urgent action, we are heading for a post-antibiotic era in which common infections and minor injuries can once again kill. Because as I told, there are no antibiotics in the pipeline for next 10 to 15 years. So we have to use whatever we have very judiciously. So global AMR, a threat to our future. The O'Neill report, which was commissioned by the UK government, has shown that if nothing is done to halt the rise in antimicrobial resistance by 2050, we are in 2021 now, so next 29 years onwards, if nothing is done for this problem, the annual death rate due to AMR could be 10 million people, and the number is huge. We all know that. So we need to be very methodical while writing and judicious in prescribing antibiotics whenever we are prescribing. When it comes to prescribing antibiotics in the ICU, I usually always tell my residents, my other colleagues, and other people who are prescribing that please follow what is called as antibiotic stewardship. We have in global antibiotic stewardship program, wherein there is restriction in use of high-end antibiotics. So we have chosen certain antibiotics like meropenem, then colistin, then tigecycline, and there are 4 or 5 more. Well, if some consultant wants to write this, they need to give explanation for the same. If some patient is already on these agents, then the report goes to the ID specialist, they review the case, and there's a discussion happening. So that's how we can curtail use. And I'm not saying you should not use high-end antibiotics when it comes to using it, but then you need to be judicious. You need to send your cultures beforehand. And after 3 days, when the culture report comes, really believe your cultures, follow your cultures, narrow down the spectrum of antibiotic. If something is sensitive, don't continue for sake of saying that, don't change the winning combination, which is usually the explanation given by a lot of consultants while using antibiotics in the ICU. With these words, we go to the next slide. COVID-19 pandemic, the new threat. This year in 2020, that is since the last year, a highly significant new threat has rapidly emerged and was declared in March by World Health Organization as a global pandemic. With the SARS-CoV-2, a novel beta coronavirus identified as the causal agent, sufferers of all ages must have mild or moderate symptoms, but for others, it can be fatal, as we all know. Those all who are diabetic, those all who are more than 60, those all who have underlying immune system which is on the lower side. This COVID-19 rapidly progressed internationally with an escalating infection and death rate that we are seeing. We are currently facing a second wave in India, and we know how many cases are coming per day, and we are on a verge of another lockdown. That is what I feel. 30th January 2020, WHO announced a public health emergency of international concern, and 11 March 2020, global pandemic was declared due to COVID-19. Very quickly, new headlines began to appear after that, linking COVID-19 to the previous global threat of antimicrobial resistance. So COVID-19 is spreading our march towards an antibiotic resistance catastrophe. COVID gives rise to potentially deadly secondary infections and antibiotic resistant superbugs. This is a well-known fact, but this does not mean that it happens in all the patients. So that's why it does not mean that you should use antibiotics in each and every COVID-19 patient, or your initial prescription for treatment of COVID-19 should never include an antibiotic, which is happening. And I think this is where we all need to curtail our use. We are known for many years that the prolonged use, overuse, and inappropriate use. So I'm saying prolonged use, that means your duration of antibiotic therapy has to be proper. Overuse, that means you need to identify where is the organism, what can be the organism, and what is the sensitivity pattern that I am usually seeing in my hospital or in my community about sensitivity of these organisms. So prolonged use, overuse, and another thing I'm highlighting is inappropriate use of antibiotics. It leads to development of antimicrobial resistance. If it comes to use of anti-tuberculous drug, this being a World TB Day celebration symposium we are discussing here, we have seen very high incidence of first-line drug-resistant tuberculosis in patients who are first time getting infected. And why this is happening? Because of inappropriate regimen being followed, inappropriate dosing being followed of anti-TB drugs, and obviously patient is at fault. Those who are defaulters are the main reason why the primary drug resistance in tuberculosis is going ahead. The principles of appropriate antibiotic prescribing developed. So the principle of appropriate antibiotic prescribing developed to help physician to remember how to avoid the development of antimicrobial resistance, states that antibiotics should be used only for bacterial, not for viral. That this is the main point I want to highlight today. It has to be used only for bacterial, not viral infection, and that it is important for physicians to, while they often have to prescribe empirically without knowing the identity or susceptibility of the infecting organism, but intelligently question to be asked, is it necessary? So treat bacterial infections only, optimize diagnosis severity assessment, maximize the bacterial eradication only for reduction only, recognize local resistance prevalence. So we all should know our local resistance prevalence and we should prescribe accordingly, and prescribe empirically but intelligently. So when it comes to word empirically, we all use this word empirically and we all use antibiotics as empirical. But then once you come to a conclusion that your empirical choice is not correct, this is not the time to use antibiotics, please stop. Please stop so that we don't reach to the next level of developing the antimicrobial resistance. As mentioned, COVID-19 is due to a viral infection. Everybody knows, and it is very clear now. And yet widespread and high level of antibiotic use have been consistently reported since the start of the pandemic. I remember initially when the pandemic started, we did not have remdesivir as an antiviral. We did not have any potent antiviral to treat this COVID-19. That time, the mainstay of treatment on the OPD basis was, I remember, azithromycin, hydroxychloroquine, vitamin C, and B complex. And later on, this azithromycin had been changed to doxycycline, wherein some case reports came from Bangladesh and they were in favor that doxycycline helps in treatment of patients with COVID-19. And that is how people have gone from azithromycin to doxycycline and augmentin and doxycycline combination being used. But as we all know, it's a viral infection, and we should change our practice as we become wiser and wiser about while treating any disease for that matter. So coming to a very recent in-crowd survey of 203 hospitals reveals a high level of antibiotic usage amongst COVID-19 patients. If you see this diagram, the antibiotic, so number one prescribed was acetaminophen, which was 80%, and number two was antibiotics, close to 40%, head-to-head with bronchodilators, hydroxychloroquine, plasma, ibuprofen, remdesivir, and antivirals. Antibiotics are used for a wide range of reasons, including as part of investigations into possible antiviral treatments. And I was telling, azithromycin, the macrolide antibiotic, has been being used since the beginning. I remember vividly initial 8 days when this pandemic was declared, and there were medicine shops which were going out of the stock for azithromycin and hydroxychloroquine, and people were trying to stock it for the future or to use for their near and dear ones. And that is how azithromycin has come in a big way in COVID. They are also used as treatment for suspected or confirmed infections, primary, secondary, or in addition, there is widespread self-medication with antibiotics in a misguided attempt to prevent infection with COVID-19 virus. As the word spreads, as the knowledge spreads on social media and otherwise, people start taking the drugs on their own without any medical advice. And as we all know, we have over-the-counter availability of everything in India, and that is how I think misuse and overuse of antibiotics is happening. Second, now coming to secondary bacterial infections in viral pandemics. With the experience of the previous pandemic, most fatalities in 1918 flu outbreak were due to subsequent bacterial infections, particularly with Streptococcus pneumoniae. So this is the history and data that is available with us from the previous pandemic. Respiratory viral infections, we all know, respiratory viral infections predisposes to co-infections leading to increased mortality. And poor outcomes in 2009 H1N1 influenza pandemic were also associated with bacterial co-infection. So this is a reality. So will this be the same scenario in COVID-19 pandemic? There is, we are learning since March last year, and 1 year has been over. But secondary bacterial infections in COVID-19, in whatever observation I have made in while working with these patients in global hospital, they are not so common if the patient is not requiring very high flow oxygen, if the patient has not been receiving any immunosuppressant medications like tocilizumab, itolizumab, immunosin alpha, all those agents which have been used to tame the cytokine storm. But yes, if these patients have underlying diabetes uncontrolled, these patients are already on high dose corticosteroid, and yes, these patients wherein the immunosuppressive agents have been used are definitely at a risk of developing severe secondary bacterial infection. And I'm not saying no to use antibiotics in these patients, but you need to select a subset of patients where you will be using. And before starting, I usually send all the cultures, and believe me, after coming my culture reports, I usually de-escalate or stop my antibiotics if the inflammatory markers and other things are telling me that no, this is not a patient where secondary bacterial infection was suspected, but then the cultures have not grown anything. So that's how we need to follow and follow the cultures and stop antibiotic if it is not used. So this slide shows a meta-analysis in COVID patients. It demonstrates that while the levels of bacterial co-infection and superinfections are low, there are high level of antibiotics prescribing, as you can see in this diagram. In this study, even though only 3.5% of COVID-19 patients had an initial bacterial co-infection and 14.3% developed a secondary infection, 71.8% was the antibiotic prescribed that was studied in this meta-analysis. So this was 24 studies included 3,000 odd COVID-19 patients, and it was done between December 2019 to March 2020. And so this clearly states that we are overusing antibiotics in COVID-19 patients, and we should not have been doing this since the beginning. Now this table shows the study from the previous slide along with a different meta-analysis in 3,834 patients in which similar figures for bacterial infection and antibiotic prescription rate were seen. And conclusions from the author of the publications were unanimous in their view that there is no evidence to support the routine use of antibiotics in patients presenting with COVID-19. As you can see, these findings do not support the routine use of antibiotics in management of confirmed COVID-19 patients. So COVID-19 patients do not need just in case antibiotics. I have seen that we always think that just in case this is required, we should use it. But an increasing number of studies have reported overuse of antibiotics in groups of patients where a much smaller proportion actually have proven bacterial infection. In a recent USA study, patients receiving antibiotics were older in a more critical condition, but testing showed that 96.5% of those who received antibiotics only had SARS-CoV-2. The authors concluded that COVID-19 patients do not need antibiotics just in case. As we all think, just in case this may be a secondary bacterial infection and we should use, but this just in case is not true. Indiscriminate use of antibiotics has huge implications for antimicrobial resistance development, which in turn has wide-scale consequences. As you can see in the slide, consequences as far as humans, their immunity, their exposure to antibiotic level is concerned. As far as water, sanitation, and hygiene, as we all know, New Delhi Metalobacter was found in soil of New Delhi. And I think this bacteria, this superbug, was given to the world by inappropriate and indiscriminate use of antibiotics in India. It also affects the food and the feed that is grown, and the same is given to the animals. We drink milk produced by cows. If they are fed on a grass or something which is already being grown by putting a lot of antibiotics and other chemical fertilizers, then you would not get a proper milk, and then your body will also have the same antibiotic resistance inside. So all these factors is leading to, because of indiscriminate use of antibiotics. So we all need to be very careful. Coming to azithromycin use in COVID-19, it's definitely a cause of concern. I will tell you why. As indicated previously, the macrolide antibiotic azithromycin, generally prescribed for the treatment of respiratory, enteric, and genitourinary infections, has recently been widely studied as a potential treatment for COVID-19 infections, either alone or with hydroxychloroquine. Major public health organizations, drug regulatory agencies, and scientific societies do not currently recommend azithromycin as treatment for COVID-19 infections. I think azithromycin is the most common and most badly prescribed antibiotic in over-the-counter as well as on OPD basis. There are a lot of general physicians who give azithromycin even if the patient has a viral upper respiratory infection, and this indiscriminate use of azithromycin is causing a lot of problems. Azithromycin, we all know, is a broad spectrum and macrolide antibiotic with a long half-life and a large volume of distribution used for treatment of respiratory, genitourinary, and bacterial infections. Studies have reported in vitro antiviral activity of azithromycin in various MOAs proposed, inference with viral entry into the host cell. Azithromycin has been proposed as treatment for COVID-19 alone or with hydroxychloroquine, but there is currently no well-controlled randomized clinical evidence to support this use. That's why we should not do that. Major public health organizations, drug regulatory agencies, and scientific societies do not recommend, as I mentioned earlier. Also, there is a cause of concern for azithromycin use with the potential for adverse events. In addition, there are several causes for concern relating to the use of azithromycin. Some macrolides known to be arrhythmogenic, and case report describe QT interval prolongation. So my word of caution to all the general practitioners who are listening to this talk to be very careful while using azithromycin. We inadvertently prescribe azithromycin without seeing the ECG of the patient. We should have always check the ECG of the patient to see the QTC interval. If the patient already has a higher or a longer QTC interval, then there is a word of caution. We should not use azithromycin in this, because with the QTC prolongation, patient can have arrhythmogenic effect in the form of torsades de pointes and polymorphic ventricular tachycardia with azithromycin. So a lot of these patients, once taking azithromycin at home, might experience these events, and somebody might have a giddiness, a fall, a cardiac arrest, so on and so forth. If you see this diagram, azithromycin, hydroxychloroquine, and chloroquine has been mentioned in this table, and a potential to cause arrhythmia. And as we all know, in COVID-19 pandemic, we have been using initially azithromycin with hydroxychloroquine, and is definitely a disaster a prescription for arrhythmia, for inducing arrhythmias. Cardiac arrest was found in 93 of 12,000 patients studied with azithromycin, and 46 of 129 patients out of 15 patients out of 129 studied. So that's why when there is such a high cause of concern and there is such a thing that patient can become arrhythmogenic and there is no indicator to use antibiotics, we should not use azithromycin in COVID-19. In addition, there is a widespread concern about rising levels of bacterial resistance following the use of azithromycin and other macrolides. For some years, antibiotic surveillance studies have highlighted the rising levels of resistance to azithromycin along with other macrolides. So even before COVID-19 pandemic, surveillance studies have showed reduced susceptibility to levels to azithromycin in patients who had Streptococcus pneumonia infection. This study in Finland, which ran for around almost 6 years and involved around 23,769 patient isolates of the respiratory pathogen Streptococcus pneumoniae, showed that use of macrolides and also azithromycin alone was associated with increased macrolide resistance in these organisms. And the authors concluded macrolide use and separately azithromycin use were associated with increased macrolide resistance in Streptococcus pneumoniae That's why unnecessary use of macrolides, especially AZD, should be avoided. This was the word of caution given by the authors of the study. In a different study in healthy volunteers now, administration of azithromycin resulted in significant increase in proportion of macrolide resistant streptococci compared with placebo. So this is a study done on a volunteer basis, and what it found. The authors in this study concluded with a plea. They just requested to the physician to consider resistance potential of azithromycin when prescribing this antibiotic. So we urge clinicians managing patients with COVID-19 to factor into consideration the possibility of development of acquired resistance when prescribing azithromycin. And that's how in future maybe we'll not be able to use this drug, and because of the more and more number of resistance coming for this. Globally, resistance levels of azithromycin have been rising. So the survey of antibiotic resistance has been running for now almost 18 years, and it focuses on susceptibility testing of respiratory pathogens isolated from the patients. So this is a busy slide. These large graphs shows the most recent susceptibility values for Streptococcus pneumoniae isolates against azithromycin, and it also includes susceptibility to amoxicillin clavulanate for comparison. We all know amoxicillin clavulanate is another antibiotic which is frequently prescribed for low respiratory infection when it comes to treating patients on an OPD basis. So this was the resistance pattern, and this was susceptibility pattern basically shown in the studies. We all need to know this. Here we can see two separate time periods. The graph shows very low susceptibility value of Streptococcus pneumoniae for azithromycin and other macrolides, and this was done in Vietnam. So very low susceptibility for azithromycin, it has started, and I think if we do a similar study in India, I will not be surprised to see the same result. 2019 WHO classified antibiotics into three groups: access, watch, and reserve. It was to assist the development of tools for antibiotic stewardship at local, national, and global levels. And I think here IMA can do a great job if we can start developing an antibiotic stewardship program which can be followed on OPD basis for all the local practitioners. Maybe we can collect the data to see what is the commonest organism causing upper or lower respiratory infection in our area, and see the sensitivity report and give them that if you find the infection in this organ or in this system, you can use this antibiotic. But indiscriminate use of antibiotics should be avoided, and we all should vouch not to use high-end antibiotics or antibiotics not use if you don't find there is bacterial infection. So I was discussing about this access, watch, and reserve group. In access, in order to improve both access and clinical outcomes, includes antibiotics that were first or second choice antibiotics in at least one of the reviewed groups, and emphasizing their role as the antibiotics that would be widely available, affordable, and quality assured. So, and the antibiotics in this group were amoxicillin, amoxicillin clavulanic acid, and amikacin. Second group chosen by WHO was watch, which includes antibiotic classes that have higher resistance potential. So drugs in this group have high resistance potential, and so are recommended as first or second choice treatments only for specific limited number of indications. And in this group, azithromycin was one of them. That's why we need to be very careful, because this falls into group watch, which has a higher resistance potential. Third was reserve, where antibiotics that should be treated as last resort, options that should be accessible, but whose use should be tailored by the highly specific patients and settings where all alternatives have failed. So these are the groups where now everything is failing and you just need to choose something, and azithromycin, fourth and fifth generation cephalosporins were chosen in this group. Coming to the National Institute for Health and Care Excellence in UK, NICE guidelines it is, they have rapidly amended a range of their treatments guidelines as a result of COVID-19 pandemic, in particular those for management of infections. This slide shows the NICE approach to use of antibiotic in these patients, and it highlights the view that antibiotics should be reserved for cases of known or likely bacterial infection, and a narrower spectrum drug should possibly be used in this. So if you find that pneumonia treatment in the community, don't use antibiotics if COVID-19 is a likely cause. Another thing is give antibiotics if likely cause is bacterial. And if you are treating pneumonia in a treatment in the hospital, start empirical antibiotic if there is clinical suspicion. Review at 24 to 48 hours. That's very important. As soon as possible, tests are available. As soon as the sputum cultures or other culture reports are available, and stop antibiotic if the pneumonia is due to COVID-19, or stop antibiotic if the cultures have not grown anything, or stop antibiotics if your procalcitonin levels are less than 0.5. Review based on microbiological results, switch to narrow spectrum as I was telling. If antibiotics are continued administered for 5 days, then stop unless clear indication. So don't continue because the patient is responding, because the patient is becoming better. Don't keep on continuing just for the sake of continuing. These NICE have also produced summary tables as part of COVID-19 rapid guidelines to guide decision making about antibiotic choice in patients hospitalized with community-acquired pneumonia. This table shows the antibiotic recommendations for adults, those who are 18, in hospital with suspected community-acquired pneumonia. As you can see, the dosing is there. Oral antibiotic for moderate or severe pneumonia, doxycycline, amoxicillin clavulanic acid is indicated. If antibiotics for moderate or severe pneumonia is to be chosen, then amoxicillin clavulanate with clarithromycin or cefuroxime with clarithromycin is the treatment of choice. So these are the recommendations, and I think these should be followed for patients who have community-acquired pneumonia. And this table refers to the adults in hospital with suspected hospital-acquired pneumonia, wherein oral antibiotics for non-severe pneumonia, you can choose doxy, amoxiclavulanic acid, Septran, and Leoflox. If antibiotics for severe pneumonia is required to be used, then piperacillin tazobactam, ceftazidime, levofloxacin can be used. If antibiotic is added, if MRSA you are suspecting, then you should choose vancomycin, teicoplanin, and linezolid. So according to the severity of the pneumonia and according to the utilization that you feel will be appropriate, you should start using antibiotic, but please narrow down the spectrum once the culture reports are available. Similarly, the World Health Organization guidelines for the management of patients with suspected or confirmed COVID-19 recommend that widespread antibiotic use should be discouraged, since this may lead to higher antimicrobial resistance, which will impact the burden of disease and deaths both during pandemic and after this pandemic is over. So this definitely a word of caution, and the guidelines is based on the 3 WHO main objectives: slow and stop transmission, provide optimized care for all patients, and minimize the impact of epidemics on health systems, social services, and economic activity. Now, what is the impact on the microbiome? What is the impact of all this on the microbiome? So this table lists a range of areas in which changes have been made due to pandemic, and it highlights the potential impact of them on development of antimicrobial resistance. As you can see, in the affected area mentioned, increased focus on hand hygiene, and what is the impact? There will be reduction in the spread of bacterial infections and AMR. Increased use of sanitizers and disinfectants can lead to microbiome disruption. If you use of face coverings and social distancing, it will be reduction in the spread of bacterial infection and AMR. Less opportunity for isolation of infectious MDRO patients, it will lead to potential spread of MDROs. If you early discharge of the patients, cancellation of routine procedures, then reduction in the patients carrying MDRO. Increased rates of empirical antibiotic therapy for patients presenting with respiratory symptoms, potentiation of antimicrobial resistance can happen. And increased rate of telemedicine within the primary and secondary care outpatient services, possible increase in community rates of antibiotic prescribing for possibly reduction in the community antibiotic prescription due to less contact with health workers and reduced access to the pharmacies. So this all can happen. That's where gut microbiome disruption implications in COVID-19, a further area which has been receiving an increasing amount of attention, resulting in rising number of publications, is the involvement of gut microbiome. Gut microbiome disruption affects a wide range of responses to infection. Our gut has a very good ability to fight as a very good immune modulator and immune boosting organ. So gut microbiome disruption affects a wide range of response to infection. In COVID-19 patient, it has been seen that there is an increased level of opportunistic pathogens and decrease in beneficial commensals in the gut. This is what is called a dysbiosis, is also caused by antibiotics. So it is like having a collateral damage. If you try to kill excessive gram-negative organisms in the body, the ones which are there but they are not so pathogenic will grow as a collateral damage and then will cause problems. So this is what is observed. So this dysbiosis is also caused by antibiotics. So reduction in the amount of antibiotic use would result in this dysbiosis also being reduced. So that's where again I am coming to the point that we should restrict our antibiotic use and we should be very judicious when it comes to using it. In addition, the overuse of disinfectants and sanitizers, we all must have all our hands of all the healthcare professionals in this pandemic must have received a lot of alcohol because of the sanitizers that we are using day in and day out for so many times. The overuse of disinfectants and sanitizers also disrupts the gut microbiome, which would have far-reaching consequences from time to come. We would definitely will have to study this effect, but I'm not saying that you should not use hand sanitizer and disinfectants before touching, after touching. So having those 5 moments of hand hygiene that we usually practice in all the ICUs, we should use, but then time to come will tell us about the gut microbiome disruption implications in COVID-19. And so let's see what it shows in the future. To conclude my topic, I would end by saying rising antimicrobial resistance is one of the biggest threat to global public health. 2020 has seen the emergence of a new global threat, COVID-19 pandemic. Excessive use of antibiotics in an attempt to manage the COVID-19 infection is contributing to rising levels of antimicrobial resistance. High antibiotic use has other consequences, as we discussed, gut microbiome disruption, which in turn reduces the patient's ability to fight infections. Antibiotic overuse is compounded by widespread azithromycin use as an investigational COVID-19 treatment. Just in case patient has an infection, we use it. Azithromycin use is concerned due to ongoing complications of torsodogenic potential and decreasing susceptibility to azithromycin and other macrolides. Major public health organizations, drug regulatory agencies, and scientific societies and clinicians do not recommend the antibiotics for the treatment of COVID-19 infection unless for a proven concurrent bacterial infections. So antibiotics are not needed in COVID-19 patients just in case that we are using it. Here is some safety information about augmentin. Very commonly undesirable side effect of diarrhea that we all see. Common undesirable side effects of nausea, vomiting, and diarrhea in children. Dizziness, headache, indigestion are uncommon side effects, but very rare antibiotic-associated colitis, including pseudomembranous colitis and hemorrhagic colitis, can happen if you use or overuse. I thank you all those who have been participating for this presentation, as well as I thank all of those on the front lines fighting COVID-19 pandemic since last 1 year. And I think our work is still not over because we are facing a second wave. With this word, I will end my lecture. I will be open for questions, if any, from the audience.
Sir, there is one question in the question answer box.
Dr. Harish Chakle?
Yes, sir.
There is one question in the question box.
Yeah.
Doctor, now did the 5 to 7 days of antibiotic regime come about? Does it not really depend on the actual eradication of the offending microbial? Should one not really clinically assess the patient, then follow this absurd rule?
Yes,
Is
I
it
think
an
it's a
absurd?
well asked and well proposed thing, because see, certain antibiotics like azithromycin has a very longer half-life that we all know. That's how not more than 5 days is required. Even 3 days are enough at times for azithromycin to take its effect, and then you should always reassess your patient whether it is still showing any signs of sepsis, any signs of infection, any signs of inflammation because of bacterial infection, and you should count your antibiotic duration according to that. It's not a fixed number for every patient and every disease for that matter, like 5 days, 7 days, 8 days course. It all depends how the patient responds.
Thank you. Thank you very much, Dr. Safle, for your very informative informations. And now we come for the second speaker. That is our own Dr. Girish Rajadhyaksha. I have a proud privilege to introduce Dr. Girish Rajadhyaksha. Dr. Girish Rajadhyaksha is a professor of medicine and head of the Department of Medical Oncology at TN Medical College and Nair Hospital, Mumbai. He is in charge of hypertension and non-interventional cardiology clinic. He did MD internal medicine from LTMG Sion Hospital. He was awarded the FAIMER USA Fellowship in Medical Education in 2010. He is the president of Maharashtra Association of Physicians 2019 to 2021. At present, he is a senior vice president of our own branch, IMA Mumbai branch. He is examiner for MBBS and MD medicine for MUHS and various other universities. He is a principal investigator for more than 25 national and international clinical trials. He has more than 50 scientific papers in national and international journals to his credit. Today, he will be speaking on TB management in 2021. Dr. Girish Rajadyaksha, please, you can go ahead with your lecture.
So thank you very much. Good morning, everybody. I would like to thank my own IMA Mumbai branch, our president, Dr. Sujatunnisa Attar, and the team for giving me this opportunity. And I would also like to thank my colleagues of the chest medicine department, Dr. Unnati and Dr. Ketki. Actually, Dr. Unnati was to speak on this particular today, but because of her own problems, so I'm replacing her. So thanking them, and I will start with my lecture. Can I share the screen?
Dr. Girish sir?
Yes.
Sir, you can open your presentation first and then click on share screen option.
Okay.
Yes, sir. Now here you can also, yes, open the presentation directly.
स्टाफ में कोई है कि नहीं है?
Now you can see.
Yes, sir.
Okay.
Yes, yes, sir. Yes, sir.
काम चाहिए? मेरे को मंगा भी लो रही है तो तुम क्या जाओ नाश्ता करो.
Just a minute. Just a minute. Hello. Hello. Hello, sir. Hello, sir.
What has happened, no? Searching girl for my debut. तो सब जरा मेरे फादर को जाके अभी कितना 5.5 साल हो गए. We have not done anything. Imagine मेरे मम्मी को 8 साल. तो all that.
Hello.
Yes, sir.
Now I can start it. Hello.
Yes, sir.
Okay. So sorry for the disturbance. Now I will start. Though the topic is recent advances in tuberculosis, more than recent advances, it is in general what is happening in the field of tuberculosis management at present and in which direction we are going, which will help us in treating the tuberculosis patients in better manner. How can we go to next? So, if you see, the India accounts for nearly 25% of the global TB burden this is the estimate in 2010, with a mortality of close to 20 per 1 lakh population. So you can see the high mortality. And if you see the prevalence is about 195 per 1 lakh population. And if you see the incidence, that is new cases, it is about 175 per 1 lakh population. The case detection rate is not 100%, it is about 74% only. Now we have to understand few definitions regarding TB. One is a presumptive TB case, so that we can say suspect TB case. Who is that? A patient who is having cough for 2 weeks or more, who has contact of smear positive TB. So TB contact, as you know, is very important. Then HIV positive patient who is having cough of any duration, and suspected or confirmed extrapulmonary TB case who is having cough for that duration. Now, as far as TB case is concerned, when you call TB, it could be bacteriologically confirmed TB case, who is confirmed by either microscopy or culture, or patient can have clinically diagnosed TB, who is not bacteriologically confirmed, but diagnosed with active TB by a clinician or other medical practitioner who has decided to give the patient a full course of TB treatment. So even that we call clinically diagnosed TB case, though it is not bacteriologically confirmed case. Any pulmonary TB case with involvement of the lung parenchyma or the tracheobronchial tree is called pulmonary tuberculosis. So broadly we say clinically the tuberculosis is classified into pulmonary and extrapulmonary. And pulmonary tuberculosis also includes miliary tuberculosis. Now if a patient is having pulmonary tuberculosis plus extrapulmonary tuberculosis, still it is included as pulmonary tuberculosis. We'll see that why. Extrapulmonary tuberculosis, any TB case with involvement of organs other than lungs. That is, for example, patient is having pleural effusion, is extrapulmonary tuberculosis. Lymph nodes, abdominal tuberculosis, genitourinary tuberculosis, cutaneous tuberculosis, joint, bones, meningeal tuberculosis, etc. They are called extrapulmonary tuberculosis. Then something called new case. The new case who has never been treated for TB or have taken anti-TB drugs for less than 1 month. So that is called new tuberculosis case. The previously treated who has received 1 month or more of anti-TB drugs in the past. Now there are some patients, and in fact many such patients we keep seeing, who are lost to follow-up. They start treatment, they come for 1 month, 2 months or some time, and they are lost to follow. So previously treated for TB and were lost to follow at the end of their most recent course of treatment is called treatment after loss to follow. Previously they were known as treatment after default, when they come back again to us. What is a cured case? A cured case is a pulmonary TB patient with bacteriologically confirmed TB at the beginning of the treatment and was smear or culture negative in the last month of treatment and on at least one previous occasion. And the treatment completed, a TB patient who completed treatment without evidence of failure but with no record to show that sputum smear or culture results in the last month of treatment and on at least one previous occasion were negative. So he is not having proof. So you cannot say he's cured, but he has completed the treatment. Now completed treatment may be cured, may not be cured. Then there is a category which is called treatment failed. Sputum smear or culture is positive at month 5. So 5 months of AKT is given properly. We are not sure whether the patient is taken or no, but 5 months of AKT. And then if you see the patient is still symptomatic and the patient is having the symptoms and the sputum or his specimen is positive, died for any reason before starting or during the course of treatment, that is another category, and lost to follow-up, did not start treatment or treatment interrupted for 2 consecutive months, we'll say lost to follow-up. Previously, again, as I told you, we used to call them defaulters. Now we come to pulmonary tuberculosis. Remember, the pulmonary and extrapulmonary division is made because pulmonary tuberculosis is a multi-bacillary form of tuberculosis. So the load of tuberculous bacilli is much more. Any other system involved along with the lungs is also termed as pulmonary tuberculosis. Now, pleural effusion, as I told you, is called extrapulmonary tuberculosis. Now, what is the best sample? If you want to confirm the diagnosis, it is deeply cuffed out sputum sample. An ideal would be an induced sputum sample, but what we take is a deeply cuffed out sputum sample in most occasions. Now, the RNTCP algorithm, RNTCP guidelines, everybody knows. If you see them, how you have to investigate these patients. So first is a pulmonary TB suspect. Anybody who is pulmonary TB suspect, who is that? A patient is having fever or cough for 2 weeks, loss of weight, history of contact with suspected or diagnosed case of active tuberculosis. Then you find out whether the expectoration is present. If there is expectoration, then obviously you take 2 sputum samples. 1 out of 2 or both those samples are positive, then there is no doubt the sputum positive tuberculosis and start with full anti-tuberculosis treatment. If both the samples are negative, then you have to give a course of antibiotics, which may be amoxicillin, clavulanic combination, azithromycin addition. So you give for about 10 to 14 days. Now, at the end of 2 weeks, if the cough persists, you repeat the sputum examination. So 2 samples of sputum are collected. If at least 1 is positive, again, you have made the diagnosis of tuberculosis and, you start tuberculosis treatment. But if the thing is negative, then you do chest X-ray and you do Mantoux test. If the Mantoux test and chest X-ray are suggestive of TB, you give anti-TB treatment, but make the diagnosis of sputum negative tuberculosis. And if the patient is negative, then needs to be worked up. So you can send to, if the patient is child, you can send to pediatrician. If the patient is adult, you can send to the physician for further management. Now, what is the problem with this approach? The diagnosis and consequent treatment could get delayed, and this delay could be really costly. The drug-resistant cases may also be missed, especially when the incidence of prime drug resistance is on the rise. So, what tertiary care setups should do in this situation? So, you do chest X-ray right in the beginning. When the patient, the clinically suspect case of pulmonary TB comes, you do the chest X-ray right in the beginning. If there are opacities or no opacities. If there are opacities, then every culture and smear is done. And on the sputum, what you do, the newer test. Newer means now it is not so new, but it is available for quite some time, but relatively new gene expert test. If there are no opacities, you have to rule out other causes of cough and fever. Now, presumptive case you have with cough, fever, weight loss, you do chest X-ray. The chest X-ray has active opacities. Then you do the sputum smear. If it is positive, then you start treatment. Negative, then you do follow gene expert protocol. Gene expert protocol, if the Mycobacterium tuberculosis is detected or not detected. If it is not detected, you treat with antibiotics and wait culture of the. If the Mycobacterium tuberculosis is detected, then it also tells you, the gene expert also tells you whether the patient is sensitive to rifampicin or is resistant to rifampicin. The sensitive, you first line anti-cox treatment is started, and still you await the culture. And if the patient is rifampicin resistant, then you start the second line of treatment and await culture and other specialized tests. Now, what are the special cases? If the X-ray shows miliary mottling, so miliary mottling, is miliary tuberculosis most likely. Get an urgent chest thorax, CT thorax, to confirm the presence of miliary nodules. So, HRCT chest is very important in this particular situation. If the patient has persistent fever and miliary nodules, you collect sputum and start empirical ETT. Remember, this type of patient has very high mortality of up to 60%. And therefore, you can't wait. for the bacteriological confirmation. Now, if the patient is having hemoptysis, that is again another thing which can increase the mortality, especially if it is massive hemoptysis. And therefore, you have to start anti-tuberculosis treatment without waiting for the bacteriological confirmation. Remember, proper ATT or anticox treatment is very important, as only this would stop hemoptysis. Hemoptysis won't stop with any other, say many times you give antitussive and all, but that is not going to stop hemoptysis. It will stop only with effective anti-tuberculosis treatment. Now we come to extrapulmonary tuberculosis. Now extrapulmonary tuberculosis, if you see, we have got common lymph node tuberculosis is very common. Pleural effusion in medical setup is very common. TB spine is again common. Tuberculosis meningitis we keep seeing, and abdominal tuberculosis. So though TB can affect almost every organ of the body, but still these 5 extrapulmonary sites are probably most common. Now, what you have to consider the important points about extrapulmonary tuberculosis. The first thing is these are paucibacillary. As I told you, the pulmonary tuberculosis is multibacillary, whereas extrapulmonary paucibacillary. And therefore, the problem is that the smear and gene expert are often negative in extrapulmonary because the yield is quite less because they are paucibacillary in nature. So attempt should always be made to get sample for microbiology. Now, supportive investigations play important role. So there are various supportive. What we do commonly is ADA, okay, in pleural effusion, ascites, CSF, etc. And if the ADA is raised, that is a supporting evidence to say that it is most likely to be tuberculosis. Now, treatment should not be given for more than 6 months for paucibacillary tuberculosis, that is extrapulmonary tuberculosis. Though pulmonary may sometimes go on for 1.5 to 2 years also, but for paucibacillary extrapulmonary TB, we should not give more than 6 months. Now, how to diagnose? Of course, the clinical evaluation is most important. Radiological, histopathological, bacteriological, serological, and some biochemical markers. So these are various ways of diagnosing extrapulmonary tuberculosis. But remember, the first thing which I told you, that is a clinical suspicion and high clinical diagnostic skills are going to be paramount in diagnosing extrapulmonary tuberculosis. Let us see the lymph node TB. You have to take detailed history. The history of symptoms like low-grade fever with evening rise, loss of appetite, going to be very important, along with the swelling. And if you examine them, the typical matted lymph nodes, softish, are very, very common. The duration of swelling is also important, whether it is progressive or not, whether it is associated with low-grade fever, etc. All these things are important. Many patients may give past history of similar lymph node swelling at the same site, maybe at the other site, and they may also give history of previous period in which they had taken anti-tuberculosis treatment. Now, some patients may have associated dental, scalp, or skin infection as well. On examination, you have to check for peripheral lymph node sites, discharge from swelling, fluctuation test, consistency, and size of the lymph nodes. And then this is the algorithm. If the fluctuant swelling is there, you can get some liquid from there, and you can do gene export, you can do smear culture, and this is helped by what is called fine needle aspiration cytology. And by this, if you detect tuberculosis bacilli, that is fine, you start. It will not detected, but if the patient is Montu test is positive and FNAC shows is or suggestive of granuloma, still I would give anti-tuberculosis treatment. Okay, if it is not there, then I will wait for the culture. The firm swelling is there the problem, and in the firm swelling, you cannot do FNAC, and the gene export is difficult. So in that case, you have to do true cut biopsy or excision biopsy. Whole entire lymph node is removed and it is biopsy. And on that biopsy, then you can do other tests as I mentioned, and accordingly you can proceed. Pleural effusion is very, very common in medical setting. All of you must be seeing large number of pleural effusion, and in that large proportions would be of tuberculosis, at least in our country. So again, you evaluate with detailed history, clinical examination. I will tell you on one thing, that when you tap this particular effusion, you get a classical straw colored fluid and a typical picture with raised ADA if you add. then that will be diagnostic of tuberculosis in most situations. So here also what is additional thing is that you have to drain and send the fluid for gene expert every culture and routine microscopy. And many people, we don't do routinely, but many people do pleural biopsy also. Because pleural biopsy is very important in giving you the bacteriologically confirmed diagnosis of tuberculosis. Now TB spine is also there. Orthopedic colleagues must be seeing more often, but we also see these patients because they come with paraparesis and paraplegia or progressive paraplegia, backache, etc., along with low-grade fever and all. So mostly affects thoracic spine. Okay, very commonly leads to formation of perivertebral abscesses or paravertebral abscesses. Uh, and these abscesses are very important because they can give you the specimen for microbiological diagnosis. Okay. Again, the treatment goes on for 6 months. MRI is an important diagnostic tool in detecting tuberculosis or pot spine. Okay, so MRI spine you do, and this is the way you diagnose, as I told you. Then we come to the abdominal tuberculosis. Abdominal TB commonly presents with complaints of dull aching abdominal pain. That is important because it's such a vague pain. But along with that, if you have fever, which other symptoms may or may not be there, but if you have the symptoms of low-grade fever and loss of appetite, loss of weight, that helps you in making the diagnosis. Now, some patients may have ascites, and when it's ascites, is relatively easy because you can remove that particular fluid, and that fluid, if you do various tests like routine microscopy, AD, etc., and if possible, gene expert, then you will get the diagnosis. So you can do ascitic fluid analysis, you can do colonoscopy, and you can take the biopsy. You can do laparoscopy, and you can take omental biopsy. And if you do laparoscopy or USG guided or CT guided lymph node biopsy, you can do. Now the deadly complication or deadly problem extrapulmonary TB is TB meningitis because it is difficult to cure. So patient presents with gradual onset of headache, malaise, confusion, and slowly they go into unconsciousness also. Sometimes they may have vomiting episodes. Now examination reveals neck stiffness. Now how will you diagnose? You have to do lumbar puncture and get the CSF. The CSF is not as turbid as pyogenic meningitis. It is more clear and the pressure is raised, the high levels of proteins, more than 1 gram per liter, lymphocyte count is increased, and the glucose is low. So that makes the diagnosis. Again, you can do ADA level here also. The ADA is raised, that will give you the diagnosis of. Now we come to the microbiology. The microbiology is very important because it is going to confirm the diagnosis of tuberculosis. So what you do? Smear microscopy, various culture method, gene expert, and drug sensitivity is also going to be very important because which drugs to be given, whether it is MDR-TB, whether it is XDR-TB. So drug sensitivity is very important. There the gene expert is important because it gives you diagnosis of Mycobacterium tuberculosis as well as drug sensitivity of the most important drug like rifampicin and INH also along with that diagnosis. So smear microscopy, we know that typically we are doing Zeal-Nielsen staining, but also we can use fluorescent microscopy, etc. It is currently the initial investigation of choice, and for follow-up also, remember the microscopy becomes very important. However, of late it is being proposed to replace it with gene expert because the sensitivity is low. For sputum, the sensitivity ranges from 30 to 50%, whereas for extrapulmonary samples, if you have pleural fluid or CSF, the sensitivity will be very low as 20%. So that's why, as I told you, because extrapulmonary, they are paucibacillary. So sensitivity obviously is much lower. Then we come to the culture methods. Traditionally, we're doing on Lowensen, Jensen medium, LJ medium. Then liquid media also are there. Nucleic acid amplification technology, okay, are also there. Solid media, remember, are simple and cost effective to use. Relatively, liquid media are more costly. But this one disadvantage of solid media is the slow growth of bacteria, and therefore you have to wait for 1 month or even more to get the report. And meanwhile, if you don't start the proper tuberculosis treatment, the patient may worsen obviously and may die also. So this is the projected time for various diagnostic tests. If you see, the LJ medium test may take as long as 2 months also, or even more than that. And therefore, you have to look at the other DSTs for early diagnosis. Now, line probe assays are available. The advantages of the test is that it detects the tuberculous bacilli and resistance to both rifampicin and iron is the most important drug at the same time from just one specimen. It reduces the time of diagnosis to just 3 days. So that is a big advantage. It is specific for MTB complex and can differentiate MTB from other mycobacteria. That is also another advantage. But what are the limitations? It cannot be used for monitoring patients on treatment because it does not distinguish between live and dead. So if the patient is cured, a patient is getting cured, and there are large number of mycobacteria which are killed, but still it will give positive reaction, and you may get confused that the patient is still positive. It is dependent on smear results and can only be performed on the smear positive or culture positive sputum specimen. That is the limitation. This is labor incentive test and prone to contamination and human error and requires lot of space. So there are some problems, but there are some advantages and disadvantages as well. Gene Expert is the most popular test nowadays. Now, what are the advantages? It detects Mycobacterium tuberculosis and rifampicin resistance from one specimen. At the same time, the processing time is just 2 hours and is specific for Mycobacterium tuberculosis complex. That means this test also can differentiate Mycobacterium tuberculosis from other mycobacteria. It can also be used on the following process sample like CSF, lymph nodes, pleural aspiration, etc. What is the limitation? It cannot be used for monitoring treatment because it does not distinguish between live and dead bacilli. Like I already told you, a small proportion of rifampicin resistance detected may not correlate with physiological resistance. And remember, this assay is semi-quantitative and defines a positive test as very low, low, medium, and high. And this grading is not reported on the laboratory result. So there is no direct correlation between expert semi-quantitative result and smear grading of scanty 1+, 2+, and 3+. So remember, if you just compare these various tests, the smear microscopy requires about 10,000 bacilli per ml of sputum to be detected. So if that many number of bacilli, so obviously if you see extrapulmonary, will have very less bacteria, and therefore it is very unlikely to give microscopy results. The culture can be positive only with 10 to 100 TB bacilli per ml of sputum. So this is a gold standard for diagnosis. The disadvantage is it takes a long time, 4 weeks to 10 weeks. Now, however, Gene Expert, if you see, requires just 130 TB bacilli per ml of sputum to give a positive result. And therefore, it is emerging as the diagnostic modality of choice. However, the main limitation, as I told you, is retreatment cases, because even if the killed bacilli are there, they may give positive report. And extrapulmonary cases, obviously extrapulmonary cases, if they don't have 130 TB bacilli per ml of the specimen, then it may come false negative. So these, is now incorporated in the guidelines. Like, so Gene Expert now, if the result is positive, if you all patients with symptoms of TB, like low-grade fever, weight loss, etc., etc., and whatever specimen according to the site of tuberculosis, like sputum, gastric lavage, lymph nodes aspiration, etc., pleural fluid, cerebrospinal fluid, etc., ascitic fluid. So whatever is available, we perform Gene Expert. So Gene Expert may be positive, and it may tell you that rifampicin is susceptible. So the bacilli are susceptible to rifampicin. If the bacilli are susceptible, then you treat as drug susceptible tuberculosis, and type 1 AKT you start. Okay, and the patient has pulmonary TB, collect one spot sputum specimen for microscopy also, and that will also confirm. If the spooner is positive, conduct contact tracing and investigate. Expert positive but rifampicin unsuccessful. We treat as drug susceptible TB, start on same regimen, collect one spot specimen for microscopy, and culture also. You have to do culture also. And follow up the laboratory results and record them in patient's treatment record. If the drug resistant comes out, then you may have to refer to the MDR treatment in this particular patient. And the patient's rifampicin report is resistant right in the beginning, then obviously you have to start with the MDR type of treatment. So if the patient is HIV positive and HIV negative also, we have to use this particular gene expert. If gene expert is negative, if gene expert positive, what I told you in the previous slide, now gene expert is negative, then you have to see the HIV status of the patient. If the HIV status is negative, you have to treat with antibiotics and reassess the patient after 1 week. If the patient has improved and become asymptomatic, no further follow-up is required. If the patient is still symptomatic, you have to consider other diagnosis. So many other opportunistic infections or other infections can occur. Whereas if the patient is HIV positive, then you have to reassess the patient clinically. X-ray test must be done and collect another specimen for culture. The X-ray findings are suggestive of tuberculosis, then treat as thus susceptible TB type 1 AKT. If the findings are negative, that is the chest X-ray is normal, then you have to treat with antibiotics and then you have to follow in the usual manner. So these are the special situations, remember, these are special conditions in which the diagnosis may be affected. The patient has liver diseases, kidney diseases, co-infection with HIV and TB is very common. The patient is pregnant, patient is diabetic, patient has seizure disorders, psychiatric illnesses. So there are various special situations in which also you have to modify your therapeutic options. So with this, I would like to stop here. I would like to thank IMA Mumbai for giving me this opportunity. Thank you so much. Dr. Anil Awad, Dr. Doshi.
Thank you very much, Dr. Girish Lad.
Girish
Rajadhyaksha. Now I hand over to Dr. Anil Awad for the further proceedings. So,
Thank you.
Thank you, Rajadhyaksha sir. And thank you, Suresh Doshi sir, for your World TB Day program. Friends, along with World TB Day, we are also celebrating the International Women's Day today. And we have one lecture on pertaining to that. And so I request Dr. Sunita Shirsagar, the chairperson of the international, give a outline of our program.
Good afternoon, friends. Welcome once again to this International Women's Day celebrations. The theme this year is choosing challenges. I think women have to always take up challenges in their life. But to choose challenges, we have to equip ourselves with certain skill sets. And one of the biggest skill set one can have is, developing emotional intelligence. And today we have a very, very wonderful and a versatile speaker from ISKCON, Prabhu Shri Shubh-Vilas, His Grace Prabhu Shri Shubh-Vilas. So he'll be enlightening on this subject. Before he takes over the mic, I'd like to briefly introduce Shubh-Vilas Prabhuji. He's here already logged in. Welcome Prabhuji on behalf of the IMA President, Secretary and all of us over here and the audience also. So friends, I will just briefly introduce him. His Grace Prabhu Shubh-Vilas, born in the southern part of the Indian peninsula. He holds a degree in electronic engineering. His multifaceted interests have led him to pursue the specialized field of patent law post-engineering. After a brief stint in the corporate world, he chose to leave mainstream society to live a life of contemplation, putting his energy into deep studies and interpretation of Vedic scriptures. He went on to become a monk and a spiritual seeker. After 11 years of monkhood, he once again set out on a mission to fulfill the objectives of his life, to spread joy and knowledge of living a life based on purity of scriptures, making scriptures not just understandable, but also practical and inspiring everyone to live a purpose-driven, meaningful life. Prabhu Shubhvilas considers the whole world his home, determined to spread the wisdom of his learnings and light the lamp of knowledge in every direction. He works with individuals, corporates, institutes, and governments around the world through exclusive workshops, seminar, training modules, and learning retreats. Today, he is an author, lifestyle coach, and a motivational speaker. As an author, writing books is an extension of his deep sense of responsibility towards society and the benefits it can derive from understanding ancient literature in its true sense. He took a monumental task of writing series of books on Ramayana that brought the epic out of the closet and revealed depth of learning. It was based on original literature like Valmiki Ramayana, Kamba Narayan and Ramayana and Ramcharitmanas. He has even gone ahead and done a PhD in Ramayana. Apart from corporate sector, his target audience is youth. He traveled across the globe, connecting with them across educational institutions. He's appointed as a faculty in Indian Institute of Management, Ranchi, and IIM Indore. He was also invited to speak at Microsoft, Amazon, and Samsung Silicon Valley. He's a regular at National Human Resource attended by top-notch HR heads. He was also invited to speak to the top-notch nuclear scientists at the Defense Research and Development Organization, that is DRDO. He recently also spoke at the prestigious Massachusetts Institute of Technology at Boston. His effortless speaking attracts hearts and minds of people across the world. That's what makes him popular invitee in countries like Australia, USA, UK, South Africa, Hong Kong, Mauritius, Far East, etc. He has a list of best sellers on Amazon. To name a few, it is Open-Eyed Meditation, 6 volumes of Ramayana, Perfect Love, Magic of Friendship, and many more. So, ladies and gentlemen, here we present to you this versatile speaker, and I request him to take over the mic and welcome you, Prabhuji, once again. And ladies and gentlemen, please lend your ears to this versatile and wonderful speaker that we are honored to have today. Prabhuji, please take over.
Thank you very much. Very, very honored to be here at the International Women's Day of the Indian Medical Association. It's such an honor and pleasure to be amidst you all. I'll just be quickly sharing a screen. So today we will be speaking on this subject of emotional intelligence, which is a very important and a very relevant subject for most people who are dealing with human beings. And obviously all of us, whether you are medical professionals, handling hospitals, handling patients, handling staff, or handling students, at whatever level all of us are, we are obviously handling people. So leadership is all about working through emotions. And therefore, this whole idea of emotional intelligence is so very important for doctors and for medical professionals to really absorb. And putting it together with this a very important event of International Women's Day. And from a woman's perspective, emotional intelligence is so very important. Obviously, it is important from a men's perspective also, but women give so much more emphasis to the importance of emotional intelligence. And therefore, it's so much relevant to discuss it on today's day and on this particular occasion. So what I'm going to be doing over the next 45 minutes or so is taking you all through a very diverse understanding of what emotional intelligence is, why it is relevant and important today, and also more than that on how to apply it and develop it in our own lives. While I'm going to be sharing so many things on emotional intelligence, I'll be telling you all many stories to connect with the subject on a direct personal level in your personal lives. And as I'm going to be telling you all these stories, you'll find these stories extremely relevant, extremely exciting, insightful, and at the same time very, very relevant to today's topic as well as today's times. Of course, almost all of us have been in the middle of so many lockdowns for the last more than a year, and that itself has taken so much toll on the mental health and emotional well-being of individuals. And this subject is going to be very crucial even from that perspective. So having given that background, I'll like to begin now. So just to give you an example how important it can be for leaders and for individuals who are handling people to be emotionally intelligent. Many years back, BBC, the British broadcasting company, they made a monumental decision by closing down one part of the organization. They had started a division on an experimental basis, and they had about 200 journalists and editors, etc., in that division. After a couple of months of working, they decided to shut down the division. To convey the information that the division is being closed, they sent one person, one executive, to go and convey the information to the 200 odd journalists. This man walked into the place where the staff was assembled, and he started talking very big about how the rival operation was doing. And he spoke about how he has returned back from a trip from the Games and how the BBC has decided to shut down this organization. And he told all of them, best of luck. From tomorrow, none of you all need to come to the office. You'll are relieved from your job. Now you can imagine the situation there. All the people, the 200 people that were assembled there, they got wild. They just couldn't handle it. And they actually began to charge on him, attack him. This security had to come and pull him out. The next day, another executive was sent. Now, this man, he took a very different approach. He spoke from his heart. And he spoke about how important journalism is. And he spoke about how important journalism is for the society's well-being. And he told all of them that none of us have come here, chosen this field because there is a lot of money in it. We have chosen this field simply because we have a passion for journalism. And he reminded about how important their role was to the well-being of society. And then he spoke about how important journalists' dedication is to their job. And finally, at the end of the whole thing, he said, we are discontinuing this particular organization. But I know that all of you will do wonderfully well in your personal careers. And he wished all of them well, and he walked away. But when he finished speaking, everyone there actually clapped for him, cheered him. Why? He spoke the same thing. He told them, you don't have to come for tomorrow. But the way he told them was so different from the way the first person told them. People, their emotions are very much vulnerable. The role of a leader is to direct that emotion in the right way. From a medical perspective, just to give you an example, inside our bodies, there are two types of systems. There's a closed loop system and there's an open loop system. Closed loop system, such as circulatory system, is a self-regulating system. What's happening in the circulatory system of others does not impact our own system. But within us, there is also another system which is known as open loop system, which largely depends on external sources to manage itself. The open loop system is also known as a limbic system. It's an award-winning system from an evolutionary design point of view because it allows others to come to our emotional rescue. Just like, for example, if a small baby is crying, a baby is crying intensely because of some problem, some pain, some problem. It's not able to understand what it is. And it's crying intensely. And the mother, as soon as the mother picks up the little baby and just embraces the little baby, the baby stops crying. The emotional stability of the mother helps the baby attain emotional stability. And that is one of the most powerful things that a human being has. The ability for interpersonal limbic regulation. And that actually scientists have really analyzed how emotions connect one another very powerfully. Just like when two people have a very good conversation, 15 minutes of very nice conversation, scientists have measured in laboratory how the physiology such as heart rate of those two people actually starts sinking. And before the conversation, they were operating at different rhythms. But at the end of a simple 15-minute conversation, their physiological profiles look very similar. And this phenomenon is called mirroring. For example, if three strangers are sitting in front of each other in complete silence for a minute, the one who is most emotionally expressive transmits his or her mood on the other two without speaking a single word. This is called emotional soup. In leadership, the whole idea about leadership is there are certain emotions that spread very fast. Like, for example, if you enter a room where 5 people have been fighting very angrily, and when you enter the room, there is silence, pin drop silence, nobody is saying anything. But as soon as you enter the room, you sense it that something is wrong here. You immediately sense there is something wrong here. And you can sense and experience anger, basically. So therefore, emotions are very, very powerful. And the way emotions are, transmitted is very, very intense. And there are some emotions that really spread much faster than other emotions. Like, for example, laughter is one of the most conducive and also it's one of the most widespread emotions, fast-spreading emotions. Like, for example, if you enter a room where people are laughing like anything, you don't know what the joke is, but you end up smiling automatically. So there are certain emotions which are very contagious in nature, and laughter is one of them. So when we speak about emotions, emotions are supposed to be at sync with one another. Many years back, when people would be taken into corporate jobs, one of the things that we look for is IQ or intellectual quotient, aptitude tests, and so many things to determine the IQ of a person. Today, when people are taken into organizations, IQ is not the only factor that is seen. In fact, more importance is given to EQ, emotional quotient, the ability for a person to handle stress, the ability of a person to work in teams, the ability of a person to handle emotions which are extreme in nature. What exactly is emotional intelligence? It's essentially these 4 things. What you can see in front of you on the screen is exactly what emotional intelligence is all about. It's about balancing 4 aspects of life. Self-awareness, which means understanding your own emotions. Self-management, which means managing your emotions. Social awareness, which means understanding other people's emotions. And relationship management, which means managing other people's emotions. So these are 4 things that constitute what is known as emotional intelligence. So I'm going to quickly give you all an overview of what these 4 things are and how we learn to deal with these 4 things. First is known as self-awareness. To help us understand what is self-awareness, I'm going to take a very simple example. I'm sure all of us have used mirrors. We stand in front of the mirror and we look at ourselves, and we admire ourselves. We see sometimes flaws in ourselves. But the interesting thing about self-awareness is that we don't understand how powerfully the way we think about ourselves is influenced by how others think about us. Let me give you a simple example from the Mahabharata. just before the Mahabharat war, Bhishma, who was a commander of the Kaurava army, he was doing an analysis of the entire army, of all the chiefs of his army. He brought all of them together and he was looking at the strengths and weaknesses of each individual in the team. And he was giving ratings to different of them. It's like a typical corporate appraisal system. So he was calling Duryodhana as Maharati. Maharati means somebody who can kill thousands of people. He was calling somebody as Rathi. He was giving different names to different people. And finally, when it came to the turn of Karna, Bhishma gave the rating of Ardharathi. What is the meaning of Ardharathi? Ardharathi means half a warrior. That means he can't even kill one person properly. It's a very insulting and demeaning rating that Bhishma gave Karna. Karna was very upset because he was bigger than a Maharati. And Karna challenged Bhishma and asked him, how dare you call me Ardharathi? If there is a rating bigger than Maharati, that's what I deserve. Bhishma explained very coolly that, my dear Karna, you have a curse on your head. And according to that curse, when you're fighting the most important war of your life, you will forget all your knowledge. So he told Karna, what is the use in you being knowledgeable at all the times, but during the most crucial period of your life, you forget the knowledge. So he said, according to me, you're useless because you're going to be useless during the most important time of your life. And therefore, Bhishma dismissed Karna. Karna was very upset. He took a vow instantly that as long as Bhishma is alive, I won't step into the war. Bhishma was alive for the first 10 days of the 18 days of war. And Karna didn't enter the war field for the first 10 days. So imagine how affected he was by the rating of Bhishma. This shows us the self-image of Karna, which is what is known as self-awareness. Very often, likes and dislikes of others affect the way we look at ourselves. Today is a world of social media. Everybody is doing this or this, right? Likes or dislikes. All the time, whatever you do, you post it on social media, Facebook, Twitter, Instagram, and you get this likes or you get this dislikes. So unfortunately, a lot of people are so badly affected by people's likes and dislikes that they form an opinion about themselves based on other people's opinion about them. I know a young boy who made his first YouTube video and put it up. And the next day he saw there were 99 likes and there was one dislike. And this boy, he started crying. I asked him what happened. He said, why did this one person not like my video? I said, come on, 99 people liked it. He said, no, that doesn't matter to me. Why this one person didn't like? The nature of a human mind is to be dissatisfied with what it has. It always looks for satisfaction in what it doesn't have. Unfortunately, human beings are so much obsessed about the way others think about them that they don't think so much about what they think about themselves. Just like, for example, if you look at this whole thing from this perspective, like say, when you are looking at yourself in the mirror, you have a certain opinion about yourself. But when your mother looks at you, your boss looks at you, your colleagues look at you, they have a totally different opinion about you. We have to learn to immaterial of what others think about us. We should focus on some aspect of ourselves which we feel proud of. Usually, people focus a lot on the way they look, externals, hairstyle, dressing style, and so on and so forth. But seldom do people focus on their contribution. Actually, only in the beginning people keep looking at you and judging you based on what you look like. But beyond a certain point, people don't care how you look because people focus on what you do. Like, for example, if you look at personalities like Mahatma Gandhi, Mother Teresa, Nelson Mandela, you look at any of these personalities, they're not the most beautiful people to look at. But who cares? Because people are so much focused on what they do that what they look doesn't really matter. And therefore, the more we focus on our contribution, our self-awareness increases. Because our self-worth is not just based on some externals or based on what some people's opinions are. Our self-worth is based on the way we contribute. And our self-worth is based on how much we reach our potential. And that's what the whole idea of self-awareness is. To go to the next point, which is self-management. To help us understand what self-management is, I'm going to give you a simple example, which all of you all on a day-to-day basis will experience. I'm sure many of you all are into shopping, or rather all of us are into shopping. So now when we go and buy anything, when we go for shopping, what exactly do we really look for? Let me tell you a story from the Mahabharata, or rather a fact from the Mahabharata that will help you understand what really is a mindset behind shopping. Now you might wonder, how is shopping connected to the Mahabharata? And you might wonder, there was no Amazon, there was no Flipkart, there was no discounts and sales happening during Mahabharata times. But the principles are exactly the same. I'm going to introduce you to a person in the Mahabharata whose name is Ashwathama. So Ashwathama was a shopaholic, intensely into shopping. And what was he shopping for? He used to shop for weapons. The interesting thing about Ashwathama was that he had many things, but somehow he never found satisfaction in what he has. And he always looked for satisfaction in what he doesn't have. When he was born, he had a jewel on his head. He was born with a jewel. And the power of the jewel was that anyone who had the jewel would never be affected by disease, would never get hungry, never feel thirsty, practically immortal. And Ashwathama, somehow, though he was born with the jewel, he somehow didn't believe that it worked. In fact, according to the jewel, if anybody who had the jewel, they could not be defeated by their enemies. But every time somebody attacked Ashwathama, Ashwathama would go and run hiding behind his father, Dronacharya. Though he had something powerful, he didn't know how to use it. Just like a lot of people have iPhones, but they hardly know to use even the basic features of an iPhone. What to speak of using the advanced features? So just because you have a high-end gadget doesn't mean that you know to use it. So Ashwathama, he had a lot, but somehow he found meaning in what he didn't have. Like one time, Dronacharya, his father, was giving the Brahmastra to Arjun. Ashwathama told his father, I also want the Brahmastra. Dronacharya said, come on, you're not qualified for the Brahmastra. Ashwathama said, no, nothing doing. I want it. Like, really intensely begging. And then Dronacharya just gave it to him. He said, take it and get lost. Ashwathama takes the Brahmastra, goes all the way to Dwarka, and he meets Lord Krishna there. And he tells Krishna, I have an exchange offer for you. I'll give you my Brahmastra. You give me your Sudarshan Chakra. Can you imagine? Krishna was shocked. He said, first of all, no one has ever asked me like this. My kids, my children have not asked me, my brother has not asked me for it, my best friend has not asked me. I mean, I didn't understand why he wants the Brahmastra. So Krishna told him, anyway, you take my Sudarshan Chakra, I don't even need a Brahmastra. See if you can handle it. Krishna released his Sudarshan Chakra. And Ashwathama, when he tried to hold it, just by touching the Sudarshan Chakra, he felt unconscious. He didn't have the capacity to hold the Sudarshan Chakra. So imagine, there is so much he has, but what he has, he doesn't know how to use. But what he doesn't have, he feels that will give him happiness. And that's exactly what shopping is. Today's world, the mind is dissatisfied with what it has. The mind is looking for satisfaction in what it doesn't have. And therefore, every single person in this world is constantly looking for change. Why we're looking for change? Because we feel that right now what I have, I'm not happy with. If I change my job, I'll be happy. I'm in this hospital, I'm not happy. If I go to this hospital, I'll be happy. I'm right now having this position, I'm not happy. If I only have this position, I'll be happy. I'm having this much of bank balance, I'm not happy. If only I have this bank balance, I'll be happy. Somehow the mind always is thinking, if I go for some change in life, I'll experience happiness. But the reality is, the nature of change is not going to make us happy. There are two types of change in this world. The first type of change is known as material change. If you look at the screen in front of you, there are 4 bottles. These are 4 bottles that come in everybody's life. There's a milk bottle, there's a Coke bottle, there's a whiskey bottle, there's a drips bottle. And all 4 bottles, whether you want it or not, it will come. Of course, some people can avoid the 3rd bottle. But the point is that this is known as go through life. This is known as change, material change. But when we actually say we're looking for change, what are we looking for? Change is a reversible phenomenon. Today, I want something, but tomorrow I may not want it. Like for example, a lot of people take resolutions, right? New Year resolutions, and focus on health. You go to Marine Drive on 2nd of January, you will find thousands of people jogging there. Why? They just take a New Year resolution. You go there on 2nd of February, it's empty, hardly anyone there. Why? Because that's how change is. Material change doesn't last for long. But when we say we're looking for change, what are we looking for? We're actually looking for transformation. Transformation is known as spiritual change. Transformation is something that is much, much higher and deeper than change. So spiritual change is when a caterpillar becomes a butterfly. That's called transformation. The butterfly cannot become a caterpillar again. A stone becoming a statue is a transformation. The statue cannot become a stone again. So when someone goes through a change that is irreversible, that is known as transformation. So when we say we are looking for change in life, we're actually not looking for change. What are we looking for? We're looking for transformation in life. And that transformation is something that is very deep. And that's something that is lasting. A lot of people, when they come across problems in life, they go through crisis. They give up. In fact, most people, when they come across problems in life, they just feel like giving up because negativity is not easy to deal with. Unfortunately, we are in a world where there is so much negative energy around us. But if you don't know how to deal with the negative energy, we will need to go to psychiatrists and psychologists because the nature of the mind is to give up if it is not held in control. There was a man who went to a psychiatrist and he told the psychiatrist that, sir, I feel like committing suicide. What should I do? The psychiatrist told him, don't worry. I'll tell you what you should do. I'll tell you what I do when I feel like committing suicide. Imagine, this man is trying to help somebody else. It's like somebody in a quicksand trying to help someone else who's also drowning in the quicksand. So this man said, when I feel low in life, I go to a circus nearby. And in this circus, there's a clown. And this clown is so funny. When I look at his act, I just completely forget all my problems. I suggest that you also should go to the circus and watch this clown. This man, he told this psychiatrist, he said, sir, I am that clown. This is today's world. Today's world, I call it as smiling faces, crying hearts. You ask anyone in this world, how are you? Big smile on the face. I'm fine. Everything is fine. But you scratch the surface. There's an ocean of misery inside everybody's heart. And unfortunately, people don't know how to deal with that negative energy. Unfortunately, people don't know how to say that I need help. The reality of today is that no matter how successful you are, at some point of time, when you come across failures, when you come across setbacks, we all need help. Unfortunately, most people do not have the guts to say, I need help. And unfortunately, a lot of people, especially those who are successful, they are the ones who are struggling with seeking help. In Sanskrit, there is a beautiful word which is known as vismay. The word vismay means wonderment. So it's called the wow factor. When you see anything beautiful in nature, you feel like saying, wow. But you know what? Today, a lot of people have become so indifferent that you bring them in front of the most beautiful creation. No reaction on their face. No smile, no crying, absolutely no reaction. Sometimes I go to these huge corporate events and I'm cracking the biggest jokes in the world. And there are people on their face, there is absolutely no emotion. At least you cry. I understand that some emotion is there. Nothing at all. There's a type of indifference that has set in society today. That indifference is actually an exhibition of lack of emotional intelligence. Laughter is so very important in life. But unfortunately today, people don't know how to laugh. They just forgotten how to laugh. There was a time when people used to roll on the ground and laugh so much. And literally tears would come out when you laugh. But today, people just don't laugh. The next generation, you have to go to laughter clubs to laugh. The generation after that is even worse. To laugh, they'll say lol, laugh out loud. That means I've laughed loudly. They'll actually not laugh. The next generation is even worse. They will send a smiley, big smiley, saying that I'm laughing loudly. So imagine, naturally, you need so many psychologists today. If you don't learn to see the lighter side of life, which is the most beautiful side of life, then you get upset about everything and anything. And therefore, the idea of having emotional intelligence is so very important to be able to see life in a positive way. This is what I call as the victim consciousness or the victor consciousness. There are two ways to look at life. The first way is known as a victim consciousness. Victim consciousness means that anything goes wrong in your life, you start cursing, you start blaming, you become morose, you start worrying. The victor consciousness is, even in the most negative situation of life, find some reason to smile, find some reason to laugh. And that's what is important in today's world. Here is a man whose name is Percy Spencer. This man, his life is tragic. And I'm going to tell you his story. When this man was just born, an 18-month-old baby, his father died tragically. His mother was not able to take care of him. So she gave him to her uncle and aunt to raise. When Percy was about 7 years old, his uncle died. And at 12 years of age, he had to drop out from the elementary school and started working in a mill at the age of 12. But somehow he was motivated to work. And as he grew a little older, at some point he started working in a radiation laboratory during the World War II, 1939. And one day he went to the lab wearing his overalls, the lab coats. And in his pant pocket was a chocolate bar. So when he went into the laboratory, at some point he felt there was something wet on his pant. He looked below and he saw the chocolate bar had melted and his entire pant was messed up badly. Percy, now imagine if you were in his situation. This man was in victim consciousness. He would have cursed fate. He would have cursed God. Because all the bad things in life are happening to him only. And he could have gone on and on and on. There are people who love to talk about all their problems, love to talk about how they are miserable, and they love to talk about it again and again and again. Percy could have easily gone on that spree, but rather he asked himself a question. He chose to be in the victor consciousness. He asked himself, why did this chocolate melt? When I entered the lab, it was not so hot. The laboratory is not so intensely hot that the chocolate could melt, but still why did it melt? He began to think, and in the next few years, he invented the microwave oven. If any of you use the microwave oven in your homes, you should thank this man. Thank the chocolate for melting in his pocket. If the chocolate had not melted in his pocket, the world would never have found the microwave oven. And more importantly, if Percy Spencer was in a victim consciousness, he would have been crying over the melted chocolate rather than inventing the microwave oven by being in the victor consciousness. And therefore, all of us in our lives, we are just like Percy. We are in a situation where we need to take charge of our emotions. And that's what self-management is about. The third aspect of social awareness is about understanding other people's emotions, which is so very important today. I'm going to tell you all a story from the Mahabharata. It's a very interesting story. It's about understanding the way others function. Arjun, when he went to the heavenly planets, he met a man named Chitrasen. Chitrasen was a Gandharva, expert musician, expert dancer, expert singer. Arjun attended one of his performances and Arjun was highly impressed. He walked up to Chitrasen and from his heart, he appreciated Chitrasen intensely. Chitra Sen was so touched by Arjun's appreciation. He told Arjun, I'll teach you everything I know. And then Chitra Sen taught Arjun singing. He taught him dancing. He taught him musical instruments. And Arjun was so grateful that he in turn taught Chitra Sen everything he knew about war, the art of weapons, the art of war. And they became the best of friends. The same Chitra Sen once came to the Earth planet and he was having a picnic with his friends. And while he was having a picnic in a forest known as Dvaipavan, Duryodhan comes with a group of his friends to the exact same spot. He tells Chitra Sen, please go from here, you can continue your picnic somewhere else. Chitra Sen tells him, I'm sorry, I came here first. You go somewhere else. Duryodhan says, this forest belongs to my father, you get lost. And they both began to fight so badly. At some point, Chitra Sen defeats Duryodhan so badly, ties him up like an animal and throws him on the ground. And Chitra Sen takes over the whole thing. Now the question is Chitra Sen good or Chitra Sen bad? The answer is Chitra Sen is neither good nor bad. Chitra Sen simply is a byproduct of the way in which you deal with him. If you treat him nicely, he behaves nicely. If you treat him badly, he behaves badly. So Chitra Sen is neither good nor bad. And that's exactly how all of us are. All of us are neither good nor bad. We are simply byproducts of the way in which we are treated. If somebody treats us nicely, we behave nicely. If somebody treats us badly, we behave badly. Human beings are like an opal stone. Opal is a very special stone. It's known as a sensitive jewel. Opal, if you look at an opal stone, it looks like an ordinary pebble. But why would an ordinary pebble be so precious and so costly, like the diamond? The reason is opal is very special because you take the opal on your palm and keep the opal on your palm and you cover your palm for a few minutes and you open your palm, the jewel will start shining like a diamond. When the jewel is provided warmth, it actually exhibits its shine. Human beings are like the opal. When they are provided warmth and affection, the best out of them comes out. When they're treated rudely and with an uncaring attitude, the worst of them comes out. All of us, as I said, we have to look at good and bad in each one of us. There is an element of good in us. There's also an element of bad in us. It depends on how you look at it. I'm going to share a very interesting story. This talks about who you are determines what you see. Who you are determines what you see. For example, in the Mahabharata, Dronacharya once called Duryodhan, his disciple. And he told Duryodhan, I want you to go into the kingdom and find at least one person who is better than you. Duryodhan walked into the kingdom, met thousands of people. He came back and said, sorry, I couldn't even find one person better than me because every person I saw had a defect which I didn't have. He had a list of names of people and list of faults they had which he didn't have. Dronacharya called Yudhishthir and he told him, I want you to go into the kingdom and find at least one person who is worse than you. Exact opposite. Yudhishthir went out. He met thousands of people and he came back and he said, I'm sorry, I couldn't even find one person who is worse than me because every person I saw had one good quality which I didn't have. Yudhishthir managed to find good in every single person and Duryodhan managed to find bad in every single person. Who you are determines what you see in others. If you are a very critical person, you tend to look at others also very critically. If you are a very kind person, you see kindness everywhere. So depending on who you are, you tend to look at others also. There is good and bad in every person. But there are 5 ways to look at good and bad. The first way is you see little bad in that person and magnify it like anything. The second way is you see good and bad, but you emphasize the bad more. The third way is you see good and bad, but emphasize both equally. The fourth way is you see good and bad, but you emphasize the good more. And the fifth way is you only see good and magnify the good like anything. Now, which, I mean, we fall in one of the 5 ways. Obviously, we're not the 5th way, that we only see good and magnify it. We're not even the 1st way, that we only see bad and magnify it. We fall in 2, 3, and 4. Ideally, we should come to a point where we can see good and bad, but emphasize the good more in others. And that's what the whole idea behind understanding people and connecting with people is. Emotional intelligence is all about understanding what people experience, understanding the whole idea behind human connections. And to be able to understand people and to be able to manage people well, you need to look at people as unique and their contribution as important. Just like there are 3 ways to look at people. There is something known as dependence. That means I totally depend on you. The second way is known as independence, that I don't need you at all. So there are a lot of people who are in one of the 2 ways. There are some people who are totally so much dependent on others, without them they can't function. And yet there are others who are so independent, they don't need anybody else. They feel I can live on my own, I don't need anybody else next to me. But the ideal way is the 3rd way, which is known as interdependence. That means I need you, but you also need me. As much as I need you, you also need me. I have some strengths, but I also have some weaknesses. And you have some strengths, and you also have some weaknesses. And that sync is known as interdependence. And that is what emotional intelligence is all about. Emotional intelligence is all about being able to understand how to connect with people and how to deal with people on a deeper and a higher level. And therefore, the 4th aspect of emotional intelligence, which is known as relationship management. Relationship management is all about managing other people's emotions. And the best way to really manage other people's emotions is to be able to understand when to not trigger them and when to trigger them. There are some times where we rub people on the wrong side. When we rub people on the wrong side, we get the worst out of them. And when we actually deal with people in the right way, we get the best out of them. And that's what the whole idea of relationship management is. Of course, the subject of emotional intelligence is a very deep and vast subject. We can probably speak on it for a couple of hours. But at this point in time, I'd like to stop and we'll take some questions if there are any, or if there's any comment or discussion, I'll be more than happy to take some. Thank you very much. Very grateful to Dr. Sunita Shirsagarji for having invited me here to be a part of this session. I'm very, very grateful to Dr. Akhtar for for his special invitation, and also to Dr. Pankaj Mandarkarji for having me here on this beautiful occasion of International Women's Day, and so to all the doctors and professionals present here on this forum. It's been such a pleasure and honor to be speaking to all of you. Thank you very much.
Thank you very much. Thank you very much, Prabhuji. Wonderful hearing you. It was wonderful hearing you. And surely we wanted, you should have continued. But keeping the time constraints, we have to end it here. We thank you on behalf of IMA Mumbai branch to you. On behalf, thank you very much. Thank you very much. And like Dr. Girish Lad to take over the mic.
Good afternoon, all. I would like to thank our speakers and panelists of today's webinar. Dr. Rishi Deshpande, Dr. Arindam Kar, Dr. Mehul Shah, Dr. Darshana, Dr. Vivek Kumar, Dr. Harish Chafle, Dr. Girish Rajadhyaksha, and His Grace Prabhu Subvilas, who showered the pulse of wisdom. I also thank our knowledge partners for the day, Sir H.N. Reliance Foundation Hospital and GlaxoSmithKline Pharmaceuticals Limited. I also thank Mr. Dipen Mehta, Mr. Chirag, and Mr. Piyush Kale from DigiShield, who have given us platform for this webinar and handled all technical details at the same time. I also thank our chairpersons for World TB Day, Dr. Suresh Doshi, and chairperson for International Women's Day, Dr. Sunita Sagarji, and observer, Dr. Yogesh Shah, and last but not the least, all the delegates for participating in the webinar to make it a grand success. Thank you very much.